Good morning. Welcome to the seventh meeting of the Joint Interim Standing Committee on Health and Human Services. Let's go ahead and will our secretary please proceed with the roll?
Senator Hardy.
Here.
Senator Harris.
Present.
Assemblywoman Gorlow.
Here.
Assemblyman Hafen.
Here.
Assemblyman Oren-Licker. Assemblywoman Titus.
Here.
Vice Chair Danyate.
Here.
Chair Peters.
Here.
Thank you so much. And just as a clear notice for the members that are attending virtually, just make sure that you have your cameras on and throughout the duration of this meeting, if you can respond whenever you have any questions. We have members that are joining us virtually and in Southern Nevada. So very excited to be here today up in Carson City. For some of the folks that are attending, I just wanted to give a clarification. We have gone ahead and moved the work session to our following meeting, so we won't be doing a work session today. I want to go over a few housekeeping announcements before we begin today's meeting. First, I would like to remind everyone to please silence all your electronic devices, especially your cell phones and laptops during the meeting. And for members joining online, of course, please mute your microphone when you are not speaking, but you can continue to leave your camera on. Additionally, I'll ask all of our presenters on the Zoom video call to leave your cameras off and microphones muted until I call up on the agenda item under which you will present, or I will direct questions to you. The Zoom video call has a chat feature. However, this feature is only to be used for technical assistance, and any links or information that you would like to share during your presentation should be stated verbally on the record. Again, there are some situations where agenda items may be taken in a different order than listed. And the committee's meeting materials can be found on the Nevada Legislature's website, which you can also sign up to receive electronic notifications related to any activity on the committee's website. If you wish to testify in person, you can please sign in at the table by the door and leave your business card. And if you do not wish to testify, you may also want to sign in just so that there's a record of who is interested in a particular topic when the committee revisits the meeting minutes. And when you testify in person, please turn on the microphones on to speak and off to listen, because we have other folks virtually and in Las Vegas. So now that I have completed with the housekeeping announcements, let's go ahead and move into public comment. So once again, public comment will be limited to 3 minutes per speaker. We will go ahead and make sure that everyone has an equal and fair chance to speak. And we also ask that you do not repeat what the previous commenter stated. And again, since we won't be having a work session, typically, it's just encouraged that individuals address any item during the work session in certain public comments. So just wanted to make that clarification for folks that are interested in speaking. But let's go ahead and begin with public comment for those of us here in Carson City. So please begin.
Thank you. Robin Reedy, R-O-B-I-N, R-E-E-D-Y. I'm the executive director. On behalf of NAMI Nevada, the state chapter of the National Alliance on Mental Illness, I would like to offer our concern about the potential impact that Medicaid policy has on our members, families, and all those that live with a mental health condition. As a matter of principle, NAMI Nevada is in support of open access to all safe and effective medications for mental health conditions as prescribed by qualified healthcare professionals. Access to meds is crucial. The state's efforts to address the ever-increasing costs of prescription drugs have led Medicaid to join the National Medicaid Pooling Initiative, NMPI, a drug purchasing tool. Pool purchasing is a concept that has value, but our concern about access has increased. How will Medicaid patients with mental illness be affected by participation in the NMPI? The preferred drug list, PDL, in Nevada is very different from the PDLs of the other 12 states participating in the pool. Kentucky lists 9 atypical antipsychotics as non-preferred that are currently on the Nevada PDL, including 6 oral medications. When a patient and their prescriber find a stable medication plan, it is extremely important to maintain it or risk non-adherence. If, as Nevada joins the NMPI, the drugs that provide stability are moved from preferred to non-preferred status on the Nevada PDL, this could have a serious impact on Medicaid recipients. The most dangerous time for an individual living with mental health conditions is a change in medications. Nevada Medicaid, through the Silver State Scripts Board, can maintain the current list of preferred drugs, transition to the NMPI, and not suffer a financial impact. A state is allowed to enter into product-specific supplemental rebate agreements with manufacturers in addition to participating in the NMPI. NAMI Nevada believes that the decision to prescribe medication to patients with a mental health condition should be based on the clinical judgment of the treatment providers. Research has shown that prior authorizations and denials for psychiatric populations results in poor outcomes, which include increased utilization of ERs, higher incarceration, and a higher usage of mental health inpatient hospitalizations. All these outcomes cost more money than what is saved in prescription costs. Therefore, it is very important to ensure that the current PDL is maintained. Thank you for your time.
Thank you, ma'am, for your comment. Is there anyone else in Carson City that would like to go ahead and do public comment at this time? Seeing none, let's go ahead to the folks in Las Vegas. BPS, is there anyone in Las Vegas that would like to testify at this time?
There's no one here, Senator.
Thank you so much. And is there anyone virtually that would like to provide public comment?
Thank you, Vice Chair. To give public comment, please press raise hand in your Zoom window or *9 on your phone to take your place in the queue. Caller with the last 3 digits, 653, you're unmuted and you may begin.
Good morning, Good morning to everyone. My name is Dora Martinez. I represent the Nevada Council of the Blind, as well as the Nevada Disability Peer Action Coalition. I want to share this information. It's a great news for people who are low vision and people who are blind like myself. June 22nd of this year, the Biden administration has helped and push out a accessible home COVID test for people who are visually impaired and blind. If you use a iOS device or an Android, they're all available on Google Play Store and iOS App Store. Download the Illume COVID-19 app. It's free. That's E as in Echo, LL Lima, U as in Uniform, M as in Mike, E as in Echo app. And once you do this to your smartphone, it will assist. It will read you the directions and also the test results. And these are all free to people who are visually impaired and low vision. And you do not need to prove that you are blind unless they ask you to. Once you go online and just type accessible COVID test, and it'll pop up. Thank you so much for your patience and have a great session. Thank you.
Caller, you are unmuted and you may begin.
Thank you. Leanne McAllister for the record, Leann McAllister. I am the Executive Director of the Nevada chapter of the American Academy of Pediatrics. Today's agenda item 8 will focus on public health, prevention, and wellness initiatives and programs to address non-communicable chronic diseases. 10 to 20 million children and adolescents in the United States have some form of chronic illness or disability. Chronic refers to a health condition that lasts anywhere from 3 months to a lifetime. Chronic disease prevention is a critical part of maintaining a child's overall good health. And although many preventative strategies are simple, safe, and effective, parents need help from elected leaders to guard against a variety of potentially serious illnesses. I am excited for you to hear today from Dr. Stephen Shane, who is the Obesity Prevention Chair at the Nevada AAP and a leader in obesity prevention. At future committee meetings, I hope that you will call on other Nevada AAP leaders to share with you ideas for legislative action that could greatly improve the health of Nevada's children. Our leaders include Dr. Jose Kukulkan Calderon, our e-cigarette chapter champion, who fiercely advocates to protect children from the many chronic diseases stemming from smoke, tobacco, and other dangerous products. Dr. Deb Hendrickson, a national expert on the impact of the climate crisis on health, who is advocating for renewable choices for consumers in Nevada, as well as support to switch from gas to electric appliances. And Dr. Terrence McAllister, who is passionate about sleep deprivation and the cost of early school start times on adolescent mental and physical health. The Nevada AAP currently has 262 members, most of whom are board-certified pediatricians, both primary and specialty care. Members also include pediatric nurse practitioners, physician assistants, pediatric residents, and medical students, all of whom live and work in Nevada and have dedicated their professional lives to the health of all children. Thank you.
Caller, you are unmuted and you may begin.
Good morning, members of the committee. My name is Sarah, S-A-R-A, Hunt, H-U-N-T, and I am the Assistant Dean of Behavioral Health Sciences at the Kirk Kerkorian School of Medicine at UNLV and the Director of the UNLV Mental and Behavioral Health Training Coalition. I am calling in support of my colleagues who are presenting today on access to mental health care and healthcare workforce needs, Dr. Stephanie Woodard and Dr. John Packham. We know that mental health concerns often present in primary care or specialty medical care settings first, so the emphasis on the physician shortage is necessary to address. As my colleagues will share today, it is equally important to respond to the critical shortages in mental health professionals in Nevada to ensure that our medical colleagues have someone to refer patients to for mental health care. Additionally, with the expansion of exciting initiatives in Nevada, like certified community behavioral health centers, and the rollout of 988 and crisis stabilization care, it is very concerning, though, that we may not be able to fully realize the potential of these programs because we do not have an adequate mental health workforce. Thank you for the opportunity to share public comment, and I thank you for your service to this committee and to our state.
Good morning, Chair Peters, Vice Chair Janate, and members of the committee. This is Joanna Jacob, JACOB, on behalf of Clark County. I wanted to give public comment today on Agenda Item 6 on improving access to behavioral and mental health care. We thank you for scheduling this item. We know that it's difficult to tackle the scope of all of our unmet needs in a single presentation, but I wanted to let the committee know that what the need that we see in Clark County goes beyond what is in the PowerPoint today. Specifically in child welfare, we are impacted on a daily, if not hourly basis, particularly at our Child Haven shelter, which is our emergency shelter for kids. The state has been working with us But one challenge that we continue to see and that they continue to see is that they cannot accept children needing a higher level of care into the Southern Nevada state facilities for behavioral and mental health needs because of their lack of ability to find staffing and the behavioral health professionals to provide the necessary care to kids, particularly those with co-occurring behavioral and medical conditions such as a mental health condition coupled with diabetes. According to the conversations we've been having with the state, these workforce challenges lead to a difficulty maintaining the staffing levels for them to be able to care for these kids, especially kids with acute behavior coupled with a mental health diagnosis. This is another pattern of denial that we have seen. We need to address the needs for these children and our most vulnerable citizens. Since we began tracking the youth that have been surrendered to our child welfare agency, we began in August of last year. 87 children have been surrendered to the child welfare agency in Clark County for unmet mental health needs only. 40 of those parental surrenders have been since January of this year. Parents are simply surrendering their kids to our system because our doors are always open and they cannot access care in any other way. We believe our child welfare system will benefit in any effort to address workforce, but our needs go even beyond just this system. Clark County administers our own self-funded health plan, for example. When I spoke to them about this presentation, they told me that we are seeing this significant lack of children's behavioral health resources, specifically facilities serving adolescents needing behavioral health care. The need is systemic, and it's impacting our employees, the staff at Child Haven, as well as the populations we serve. This is a very serious issue. I know that you are aware, and I thank you for having this conversation today. We are hoping to continue to work with the state, with this committee and the legislature overall to address these critical needs. Thank you.
If you have recently joined the call and would like to give public comment, please press star 9 on your phone to take your place in the queue.
Good morning, Chair Peters and members of the committee. For the record, Carrie Harrington, Executive Director with the Nevada Cancer Coalition. We're your statewide nonprofit bringing together healthcare entities and experts, state and local government, and ancillary services to work toward reducing the burden of cancer and increasing access to healthcare for Nevadans. I have submitted our comments via email as well. The burden of cancer is great in our state as it's the second leading cause of death and second most costly chronic disease, only behind heart disease. The World Health Organization reports that between 30 to 50% of cancer deaths could be prevented by modifying or avoiding key risk factors and implementing existing evidence-based prevention strategies. Chronic disease prevention results in lower healthcare spending overall, less strain on our healthcare system, fewer bankruptcies filed by families who've received these diagnoses, and fewer people undergoing treatment that leave them physically and emotionally scarred. So imagine nearly 8,200 Nevadans every year who never have to hear you have cancer. And imagine saving more than $48 million annually in Medicare costs. So to truly prevent more cancers and improve the early detection of cancer and other chronic diseases, we have to invest in prevention strategies and remove barriers to cancer screening. Historically, Nevada does not invest in these. We've typically relied on federal funds that may trickle in for such programs, and we're really thrilled that you're talking about all of these possibilities today. We strongly encourage members of the committee to consider the following policy recommendations so that we can equitably protect the health of Nevadans and reduce the burden of cancer and all chronic diseases plaguing our state. So we're providing full and consistent funding to our public health programs in the state that are already working to reduce cancer and chronic diseases, including our cancer control, tobacco control, and obesity programs, Women's Health Connection, and colorectal cancer screening program, which was one of the programs that went away when we lost federal funding for that. Requiring comprehensive physical fitness and health education in kindergarten through grade 12 to help reduce our obesity rates, increasing tobacco restrictions and working on the Nevada Clean Indoor Air Act, ensuring full coverage with no out-of-pocket costs for breast cancer screening and diagnostic services, and also prioritizing infrastructure and built environments such as bike paths and parks, walkable communities, and community grocery stores. So here at Nevada Cancer Coalition, we're truly looking forward to working with you all and serving as a resource during the upcoming legislative session as we all work to protect and improve the health of all Nevadans. Thanks for everything that you do for our state, and thank you for your time.
Vice Chair, there are no more callers for public comment at this time.
Thank you so much. Let's go ahead and move on to agenda item 3, approval of minutes for the meetings on March 24th and April 21st, 2022. Members of the committee, are there any questions regarding the minutes? Assemblywoman Titus, go for it.
Yes, sir. If I might, I'll move to approve the minutes from the 24th and April 21st, if the chair or assistant chair is ready.
Thank you so much for the motion. We have a motion from Assemblywoman Titus. Is there a second?
I would second Assemblywoman Peters.
Thank you so much, Assemblywoman Peters. We have a second for the motion. Are there any comments or discussion on the motion before we vote? Seeing all in favor, please say aye. Aye.
Yes, Yes, there is a comment before we vote.
Senator Hardy, please proceed.
Thank you. On April 21st, and this has been an ongoing question, on page 60 of the minutes, I asked a question about reciprocity of the compact, and Mr. Macaluso said he would get the answer to the staff. And I'm curious, when we ask for an answer and we get the answer, who gets the answer? Do we all get the answer? Do we not get the answer? If the answer comes, where is it?
I'm going to go ahead and redirect that question to Mr. Ashton.
For the record, Patrick Ashton, Legislative Council, Senator Hardy, I can look into this and see if we can still get this follow-up. And once we receive it, it usually goes to Chair Peters and then is uploaded on the committee's website. But I will make sure to follow up with Mr. Macaluso and see what I can get for you there.
So if I could follow up on the website, does it get attached to the minutes on the website, or is it a separate thing on the website under other, or where is it on the website?
Mr. Ashton?
For the record, Patrick Ashton, Senator Hardy, it will be included on the bottom of the meeting minutes. And to my knowledge, it's also distributed to members if there's a follow-up item.
So if it's distributed to members and one of us didn't get it, then maybe others didn't get it either?
For the record, Patrick Ashton, Senator Hardy, for this question, we did not receive a follow-up, but generally when we receive a follow-up, it will be included in the meeting minutes and also uploaded on the website. And there is an email sent out that there's additional meeting material for the meeting coming up. For this particular question, I'm pretty sure, and I will check again, but we have not received a follow-up. I can go ahead, follow up with Mr. Macaluso, and then upon approval of the chair, we can distribute it to the members and upload it on the committee's website to be available for the public. I hope that answers your question, Senator Hardy, but I'm happy to follow up with you as well after the meeting on this item.
Appreciate it. So if we can have some kind of understanding. Thanks. Bye.
Thank you, Senator. I do receive those follow-ups from staff and approve within a couple of days of receiving that, depending on my day schedule. And then they're really great about following up with that. I know that in our emails, sometimes things can get lost. I've had to put a filter on my email to make sure that I capture all of LCB's emails as they come in. But we will follow up and make sure that that is provided back to the committee, and I'll make sure that everyone gets access to that, and we post online. I do try and be very transparent in this committee and make sure that what we receive as follow-up is presented to staff or by staff to our committee members and posted on to the appropriate meeting page as follow-up, because I think that our questions are valuable and valid, and those follow-up items do help us make policy decisions. So thank you for bringing up that we missed that follow-up potentially, and I hope we can get that to the committee members in a timely manner.
Thank you so much, Chair Peters. Senator Hardy, do you have any other follow-up questions beyond this?
Thank you for that commitment and that follow-up. Appreciate it. Thanks, Mr. Chair.
Thank you so much. Do we have any other comments from any other of the committee members at this time? Seeing none, let's go ahead. So once again, we do have a motion from Assemblywoman Titus, seconded from Chair Peters. All in favor, please say aye. Aye. Any opposed?
Aye.
Thank you so much. The motion carries. Let's move on to agenda item 4, consideration of regulations proposed or adopted by certain licensing boards pursuant to NRS 439B.225. Mr. Eric Robbins, our Principal Deputy Legislative Counsel, please proceed when you're ready.
Yes. So for this agenda item, we have 3 regulations for the consideration of the committee today. LCB file RO43-22 and RO48-22 are both from the State Board of Health, and RO61-22 is from the State Board of Nursing. And we should have representatives from the 2 different regulatory agencies behind these regulations who are available either virtually or in person to answer any questions the members of the committee might have concerning these regulations.
Thank you so much, Mr. Robbins. As a reminder to the committee, this is informational only. Staff have informed you about the status of the regulatory process of these regulations that we are considering right now. And I want to go ahead and, if you have the opportunity, if there's any questions regarding them, we can go ahead and proceed now. It looks like Assemblywoman Titus, you have a question, so please proceed.
Thank you. I have a question regarding the regulation RO48-22 by the State Board of Health. And under the notes that we received, it apparently has not been scheduled for a hearing yet or a vote yet through the leg op because it hasn't gone out to impact statements yet. Is that correct, to small businesses? Can you clarify that?
As far as I am aware, that is the case, although if a representative from the agency has any update on that, they're more than welcome to step in and supply that.
This is Letitia Metherell for the record with the Bureau of Healthcare Quality and Compliance. We're currently undergoing the small impact study. We're expecting all the responses to be in by the end of this week, by the end of Friday, and start the analysis next week.
Okay, thank you for that. And if I might have a follow-up question on that. Actually, on the very first line on section 1, it seems like it expands the chief medical officer's abilities dramatically with one kind of stroke of the brush, and I have concerns about that because it doesn't really say what information he might actually request. And I'm just wondering, when you've reached out, who have you reached out to on this impact? Because it doesn't really. I'm just concerned about that amount of open-ended power that he might have and requesting information.
For the record, so far we've sent it out to all of our licensed healthcare facilities, and we are still waiting for the feedback. We have not sent it out beyond that I'm aware of, but I will definitely note your concerns and bring it back to our administration.
Right, because the word says the chief medical officer may require any person or entity in the state, and so any person, any entity is just about everybody here, and so I'm just very concerned about that language.
Yes, I will definitely bring back the concerns to our administration to discuss that. And also review the analysis and see if we get any feedback on that section from our health facilities.
All right. It doesn't say limited to health facilities, though. That's my concern.
Mr.
Is there
Robbins,
some clarification on that?
Mr. Robbins, did you want to go ahead and clarify?
So I just wanted to note that NRS 233B.039 says that the regulatory adoption process does not apply to any order for immediate action, including made under the authority of the State Board of Health in the discharge of a responsibility for the preservation of human or animal health. And so basically the State Board of Health, as we interpret it, it would have the authority to impose reporting requirements, immediately to respond to a pandemic anyway. So this regulation doesn't really, as we would interpret it, expand the authority of the State Board of Health so much as it just states their intention to do that. And so, I mean, again, this isn't really an expansion of authority so much as a restatement of the authority that they already have under statute.
Thank you so much. Assemblywoman Tice, did you have?
No, I still have great concerns over it. Thank you.
Okay. Thank you so much. Any other questions from any other committee members at this time?
Mr. Chair.
Senator Hardy, please proceed.
Thank you, Mr. Chair. I looked at this, and as I see it, and this is going to go to the Legislative Commission, obviously, if the chief health officer determines that a pandemic exists and a pandemic exists, the officer may require any person or entity in the state to report to the chief health officer as opposed to do something else. And so I think the reporting process of that is probably a little different than having to take some kind of action. So, for instance, if to Dr. Titus's point, any person, so let's pretend that there is a COVID issue that has happened, and if you do a home test that's positive, then the chief health officer may require that person who did the home test that was positive to report. And that's how I read that this could happen, and I suspect that's what they meant. But we have a lot of home tests right now that aren't reported, and this would may require such a person to report the positivity of a home test. And I think that's what it says. In essence, that could happen. And I'm sure somebody with the chief health officer's people are on the line and could say if that's the intent, to get home tests reported, if that's what they're after. Question mark.
This is Netherell for the record. Yes, the intent was to be able to do something similar to that. I don't know if it was specific to, it's not necessarily just specific to that, but to be able to obtain the information we need during a pandemic in order to be able to carry out the workload of the, of the division. And so early on, we ran into certain difficulties with reporting from laboratories from outside of the state and things like that. So yes, and if the division felt that there was a need to collect information on home tests, but it was basically limited to the pandemic or epidemic for that particular reason versus making it at any time to help facilitate those needs.
If I may, Mr. Chair.
Please proceed.
So what I'm hearing is, yes, the intention is to be able to get home tests reported, and the comment is made that we had difficulty getting entities outside of the state to report, and obviously we don't have jurisdiction outside, nor does this require outside people to report because it says in this state. So that's just an observation that may or may not want to be edited at some point before it comes to the LegCom. Thank you.
Senator, I appreciate that.
Thank you so much, Senator Hardy. Again, I just wanted to reiterate that for those of us that are interested in participating in the development of these regulations, that we have the ability to do so. And, you know, we don't approve or deny any of these regulations before today, but I encourage all the members on this committee to follow up if need be. Do we have any other questions at this time from any other committee members regarding the presentation? Seeing none, let's go ahead and continue on with any additional agenda items. Give me 1 second. Great. Okay, so let's go ahead and move on to the next agenda item, which is the overview of community health workers and Medicaid reimbursement for such workers in behavioral health care settings. We have Jay Colbert, which is the program manager of the Nevada Community Health Workers Association. So please proceed when you are ready.
Thank you, Chair Peters. I believe we're set up. So my name is Jay Colbert Clausel, for the record. Thank you for having us here again to do follow-up on the great community health work legislative effort that you put into the last session. This is our team. So we've grown quite a bit since you approved community health work reimbursement in Medicaid. We're a very diverse group across the entire state, representing rural areas, Reno, and the Las Vegas area. So just a quick overview on what is a community health worker. So community health workers are frontline public health contacts. They help bridge the gap between the services that are available and the services that people are willing to accept and kind of engage and learn how that they can live healthier lives. We have state certification for community health workers. They take an 8-week course and must be supervised to really do their work correctly with the right health team to refer people to. They reduce ER, readmission, and urgent care reliance, and they extend the reach of our licensed healthcare professionals. Community health work is an entry-level place for many people. Now, our students range in age from 18 to 97. So not everyone is on the track to become a social worker or a nurse, but the community health worker is a place that anybody can kind of be trained and bring the expertise that they have about their community. 3% of our students are American Indian or Alaskan Native, 3% are Hawaiian or Pacific Islander, 24% are Black or African American, 31% are Hispanic, and 32% are rural. So you can see how these are the people we want to incorporate into our healthcare system. There are training programs across the state. The Nevada Community Health Worker Association has had about 500 students sign up so far this year. So just really tremendous growth. TMCC has an online program that they operate out of Reno. CSN has online and in-person that they operate out of Las Vegas. CASAT has the Peer Support Specialist Program, and we often share funding and are always talking about how we can support those frontline workers, because they're training peers, and then many of their peers do get cross-trained as CHWs. And I'm proud to announce that there is a new High Sierra AHEC community health work program to improve that pipeline, and that one specifically to get people into those higher careers right at the beginning of their education. They started that this summer. CHW training was developed nationally. We use, with DPBH, we use a curriculum that was developed by the state of Washington and Massachusetts, and then we are heavily influenced by the programs in Texas. This is the same curriculum that the new High Sierra AHEC program is using, and shares all the same competencies as the TMCC and CSN program. These are the 13 competencies that the Nevada Certification Board has adopted from a consensus. So in social work, oh yeah, I forgot to introduce. So I have a master's in social work. In social work, we have a governing body at the national level that kind of defines what things are. But in community health work, it's been more organic. So we're all voluntarily moving in the same direction, where we're using community health workers in the same way and growing depending on the individual state's environment and the needs that are there. So Promotorius, actually, we're the first community health workers in Nevada working out of rural areas, but now we have community health workers across the state. So in the last legislative session, AB 191 was passed with unanimous support. It's a very short bill that just empowered Medicaid to allow reimbursement for community health workers. One important thing to note is it does not exclude behavioral health. The fiscal analysis really looked at, well, what narrowly can we tackle to get things started to approach this new reimbursement and service model conservatively. And so the fiscal analysis looked at chronic disease prevention and management, and that's what moved forward. The CHWs must be employed and serving the same clients as the physician, physician assistant, or advanced practice registered nurse. All of this infrastructure has been developed by the Medicaid office. And go ahead and hop a little bit. So with Medicaid reimbursement, I jumped ahead a little bit, but those settings can be in clinical settings or community settings. So the CHW might be based with a physician, but they can go into the churches, they can go into the schools and other community centers to provide services and work with clients and help them really adopt the health practices that are going to lead to healthier lives. So in February, we began enrolling CHWs in Nevada. And just a few days ago, July 7th, the CMS, I think it's Center of Medicaid and Medicare Services, so the national level, approved the state plan amendment. So the CHWs must receive certification from the Nevada Certification Board. That's also where complaints would be moved forward. And the CHW has an agreement that they sign that is on file with Medicaid on the scope of work and where that community health worker will be providing services. So challenges and opportunities for CHWs in behavioral health. I took this picture out in Tonopah a few days ago. We have a lot of areas where we need our licensed professionals to have a longer reach, a further reach, and to spend more time with clients. So with the Medicaid reimbursement, that's an extra 12 hours per month that the health system gets to engage with the client. If we look at Medicaid funding in other states, no other states have it restricted at the level that we do, with physician, physician assistant, and APRNs being the only supervisors for Medicaid reimbursement. I think I'll ask if there are specific questions about this, we could come back to it. I think what it boils down to is that state licensed behavioral health supervisors will enhance CHW services across the state because they have a longer history of supervision experience with CHWs and close ties with the community. And I put that statement on there because we're doing a lot of education for our physicians, physician assistant, and APRNs so that they feel comfortable supervising CHWs because they hadn't historically. Let's see. So some of the goals today would be to increase the awareness of the Nevada Certification Board that also oversees peers, certified prevention specialists, and doulas. Increase the employer's scope of work knowledge for CHW's peers and other paraprofessionals, and then open career paths to the diverse CHW workforce in public health. So for our recommendations, we'd like to investigate the NRS language to recognize CHWs in other settings and with other staff funding mechanisms. The current language is very specific to Medicaid, but we have CHWs who are funded in other ways and are also making use of the Nevada state certification. Like we contract 62 CHWs across the state through the CDC Health Disparity Grant, for example. And they have a slightly different scope of work than in a Medicaid or a medical setting specifically. Also, that we have evidence now that appropriately supervised CHWs will reduce the cost, $2 for every $1 spent in Nevada. And we believe that that will apply to the behavioral health setting. It's working at Renown, and it's working in our justice system, and even in our food pantries when those CHWs are helping connect people to services. We'd like to look at the legislative authority to Medicaid so that they could include other qualified supervisors. Right now, our language is more restrictive than any other state in who can supervise a CHW. And then add CHW certification to the NRS definition of community health workers. Right now, certification is not listed. It does say that they're not a licensed professional, but it doesn't mention the certification that is available. So for additional information, I have my contact here. And then we also have the references for where a lot of the research came for this, and then where you can find information on the Nevada program as developed by the Medicaid office. And we have an abbreviations page. So let's see. Oh, Centers for Medicare and Medicaid Services. I had the C wrong. And I'm now available for questions. And then there are also people on the line, like Dr. Let's see, Woodard. And let's see, did you want to share any, or was it?
Thank you so much, Jay, for the presentation. We have Dr. Antonio Capurro, who's a Deputy Administrator in the Division of Healthcare and Financing Policy. If there's any members that have any questions more on the reimbursement or Medicaid part. Members, do we have any questions at this time? Don't see any here. Senator Hardy?
Thank you, Mr. Chair. I think this is wonderful, and I'm grateful that it's trying to expand. I'm not sure I understand the mechanics. When Medicaid covers this, does the check go to the CHW, or does the check go to the supervising doctor and the doctor pays the CHW, or does the doctor hire a CHW and then bills Medicaid through the doctor's number? How does it work?
Dr. Capurro, did you want to answer that?
Yes, thank you so much for the question. This is for the record. So within Nevada Medicaid, what we require is for the community health worker to be enrolled with us as a provider type. They must, as a PT 89 is their provider type, they must enter into a collaborative supervisory agreement with a licensed professional, as listed in the bill. That includes a physician, physician's assistant, or advanced practice registered nurse. What we have interpreted that supervision to include is direct and indirect supervision. So both the licensed provider and the community health worker have to agree to this collaborative understanding, and it has to be submitted for the community health worker to enroll. Once the community health worker enrolls, they work under that supervisor's license. And so only that licensed professional receives the reimbursement for any services that are provided. I hope that helps to answer the question, but I'm happy to answer any.
Yes, so I understand that then. So the licensed provider gets paid by Medicaid, and then that licensed provider in that collaborative agreement has agreed with the CHW person how much that person is going to be paid, either as a salary or as a piecemeal or as a whatever agreement they come up with. That's the agreement how the community health care worker gets paid.
Thank you for the question. This is Dr. Kapuro for the record. Yes, that's correct. Just as we would reimburse any non-licensed professional that's working under the license of another entity, it's the entity that's enrolled with us that would be receiving the reimbursement.
So in trying to get more of these people, what is the usual and customary wage that a doctor, for instance, would pay a community health worker so that we can say, oh, they make X number of dollars per hour? Or how are we going to recruit if we don't know how much they're going to be paid?
Hello, this is Jay Colbert-Classell for the record. Thank you, Senator Hardy, and through you, Chair Peters. It is market driven. So there's a lot of diversity in how CHWs are compensated. The reimbursement rate, if you kind of conservatively map it out and allow for non-reimbursable activities like scheduling, you're looking at about $48,000 per year available. So that would work out to about $17 per hour. But the reimbursement changes depending on the number of clients that are being served at a time. So CHWs that receive more advanced training and can do group classes, the reimbursement goes closer to $100 per hour.
So it's what we call a good job that will save money for Medicaid and save money for the patients. And I think if we bring this up, that not only can you have a good job, but you can make a good wage and it would be good for everybody. I think we have to have a PR program that says, do it. It's a good deal. I'm off my soapbox. Thank you.
Thank you so much, Senator Hardy. Any other members or any other questions? Seeing none, thank you so much to our presenters. Let's go ahead and move on to the next agenda item, which is agenda item 6, improved access to behavioral mental health care in Nevada. We have Dr. Woodard, who is the Senior Advisor on Behavioral Health at the Division of Public and Behavioral Health. So, Dr. Woodard, please proceed when you are ready.
Good morning. I'll just share my screen with you. Are you able to see my slides?
Please proceed.
Wonderful. Great. Good morning, Chair Peters, Vice Chair Donate, and members of the committee. My name is Stephanie Woodard, and I serve as the Department of Health and Human Services Senior Advisor on Behavioral Health. Thank you for the opportunity to speak with you all this morning about an issue that continues to be one of the most pressing issues impacting Nevadans, and that is access to behavioral health care in Nevada. This morning, I will present on several policy opportunities for this and other decision-making bodies to consider when seeking to make meaningful, sustainable improvements in access to behavioral health care in Nevada. Let's see if I can't get my, there we go. Many of you are probably very well aware of the Mental Health America report. They've been publishing a report annually for the last 8 years, which talk about a number of different elements that include access to care. We have updated numbers that have not been calculated yet into a Mental Health America report, but these numbers I do think reflect very high level some of the elements that are critical to determining how individuals are accessing care and the approximate prevalence of some of these issues in our state. So these numbers are specific to Nevada, and this was produced through the National Survey on Drug Use and Health. This is an annual survey that occurs across the United States and typically is held as the gold standard for estimating prevalence rates across a number of different indicators in behavioral health. So according to this survey, they estimate that in 2020, the number of individuals over age 12, so this is age 12 and up, in Nevada meeting criteria for a substance use disorder in the past year was 371,000. Now, if you look just below to individuals needing and not receiving substance use disorder treatment in a specialty facility, and specialty facilities are classified as facilities that are specifically geared towards addressing individuals with relatively severe and acute substance use disorders. Those needing and not receiving substance use disorder treatment in a specialty facility was approximated to be 355,000. So you can see that there is a very significant gap between the number of individuals that are presumed to have a substance use disorder and those needing care but not accessing that care. Similarly, we see prevalence rates that are estimated for individuals in Nevada meeting criteria for any mental illness in the past year. Those estimates do not include youth. There is a different tool that is used in those data. I did not review as part of this presentation, but for adults age 18 and older, the approximate estimate for individuals meeting criteria for any mental illness in the past year is 508,000. And again, we see another gap between those who could meet criteria in the past year and those who received mental health services, for those 18 and older being approximately 332,000. In past years, for the Mental Health America report, the most recent one was published in 2022. However, they used data from the 2018-2019 survey, the same survey that this data comes from, but a couple of years older. According to a compilation of data that they put together to look at access to care, adults and their ability to access care, Nevada ranked 40th out of 51. And youth, Nevada ranked 51st out of 51. Overall access to care ratings, which really compile a number of different variables for adults and youth, ranked Nevada at 39. I think this is incredibly important to consider when we look at all of the various policy levers that we have available to us to look at how do we actually increase access to care. I was listening actually very closely to some of the public comment that was given just prior to the presentations today. And I do think that it underscores some of the data that was presented and certainly highlights some of the work that we have been working with Clark County on. When they say that 87 youth have been relinquished to child welfare, with the primary reason of parents feeling unable to meet the primary behavioral health care needs of their children, with 40 of those children just being relinquished to child welfare since January of this year. This certainly does continue to underscore the difficulties that parents are having in accessing timely and appropriate care for their children. One of the biggest drivers that we have related to access to care in Nevada is our workforce shortages. And I cannot highlight enough the importance of addressing some of these workforce shortages, considering that Nevada has 94.5% of the state's population living in a mental health healthcare professional shortage area. When we start to quantify this, not just in generalities, but when it compares to what we would need in order to just be average, John Packham and the Nevada Health Workforce Research Center has been able to track and compile this data over many, many years. And we can use this data to really guide our work to look and see where the state compares nationally. According to this research, in order for Nevada to just be average for the number of clinical professional counselors per a population of 100,000, we would need 1,074 additional clinical professional counselors. Licensed clinical social workers are estimated to need 18. We are actually meeting and exceeding what would be considered the national average for marriage and family therapists. But when we look to psychiatrists and psychologists, we again see some very profound differences in what we currently have to what we would need in order to be just average. This continues with an analysis of our school-based behavioral health providers. And we know that providing behavioral health services within schools can certainly help to provide prevention and early intervention services to youth, but also extends beyond that, including making sure that we are adequately identifying, assessing, and qualifying children who may meet criteria for a 504 accommodation or an IEP for any kind of behavioral health disability. So in order to do this contrast, what has been identified is that for school psychologists, we would need 3.7 times as many as we currently have. And what is most startling is for school social workers, based on the current Nevada ratio versus the recommended ratio, we would need 35 times as many school social workers as we currently have available to us. And consistently, school counselors, our Nevada ratio is about 544 per school counselor. The recommended ratio is 250, meaning we would need at least twice as many school counselors in order for us to meet the recommended ratios. Workforce is one of the critical issues that plays into access to care. And I think it's important for us to understand what exactly we mean when we talk about access to care. So the Centers for Medicare and Medicaid Services define access to care as the degree to which individuals are inhibited or facilitated in their ability to gain entry to and receive care and services from the healthcare system. And they include some of the factors that drive this as the ability to have geographical distribution, as well as financial considerations and others. The Healthy People 2030 goes a bit further and talks about access to comprehensive quality healthcare as important to promoting and maintaining health, preventing and managing disease, reducing disability and premature death, decreasing health disparities, and achieving health equity for all Americans. And they continue to sort of distill down some of the primary components, including insurance coverage, timeliness of care, accessibility of primary and preventative healthcare services. So when we break access to care components down into their parts, it typically consists of 4 primary components. Coverage, which is essential to facilitate entry into a healthcare system. And it also looks at the extent to which services are covered. We also look at accessibility of services. So although services and supports may be covered under one's insurance plan, we look at some of the issues as it relates to accessibility. So can the individual access routine care, screening, and preventative services? And are they, with timeliness, able to provide those services in a way that is timely based on when and where an individual needs care? And of course, one of the foundational underpinnings of access to care is, do we have a workforce that is capable, qualified, and culturally competent to provide those services that are covered? We cannot talk about access to care without talking about behavioral health equity. It is defined as the right to access quality health care for all populations, regardless of the individual's race, ethnicity, gender, socioeconomic status, sexual orientation, or geographical location. And it includes the entire continuum of care, from prevention to early intervention and treatment and recovery services for mental health and substance use disorders. They also go further to identify that social determinants of health, which we all know can both facilitate or prevent or create significant barriers for individuals being able to access care, as key factors to be able to consider when we're looking at behavioral health equity and its confluence with the factors for access to care. So while access to care can be broken down into its 4 primary components, none of these components can exist without the other, and they are interdependent on one another. All of them, when they work together, can work to support a system of care and access to care that promote health equity. So let's break down a little bit of what we mean by access to care and coverage and some of the policy opportunities that states have to consider when it comes to behavioral health coverage. Certainly the Mental Health Parity, Addiction, and Equity Act, also known as MAPIA, has been a primary driver in ensuring that we have what we would consider parity across both physical health care services as well as behavioral health care services within any health entity that is providing that coverage. And there was work that was done through Nevada this past session to really work to identify ways to monitor whether or not health insurance plans are actually meeting the requirements under MAPIA and parity. States also have the opportunity for Medicaid expansion. Nevada has done that. And what we see is there are also opportunities when available to expand the qualifications for beneficiaries. And sometimes that means extending coverage or changing the coverage variabilities to ensure that we have greater access to coverage for some of the most vulnerable in our state. Affordability of healthcare plans is also an essential component. While people may have availability of coverage, the affordability of that coverage can certainly impact whether or not people are taking advantage of the coverage that's available to them. And we know that while individuals may have coverage, they may not necessarily know how that coverage works. So transparency over what is covered, but also ensuring that people know how to optimize their healthcare coverage can go a long way. And so health literacy promotion is an important factor to consider. We also recognize that there are individuals that are uninsured or underinsured. In the state, typically is the requirement to meet the needs for safety net services. So also making sure that those safety net services are broad and expansive and can help to meet the needs of individuals when and where they need coverage. And then also considering some all payers coverage requirements. We have some inequities even within our state Medicaid agency and our coverage. So for individuals with behavioral health conditions that are covered under our managed care contracted services, those managed care entities have the ability to use what is called the 15-day in lieu of rule to be able to provide services to individuals in institutions of mental disease. Our fee-for-service recipients or beneficiaries do not have that same level of coverage. And when many of the inpatient services that are needed are in private institutions of mental disease, what it does is it creates a considerable issue around access to care for those fee-for-service beneficiaries. There are other covered services, including value-added services that individuals who are covered under managed care have access to that our fee-for-service beneficiaries do not. Utilization management, quantitative and non-quantitative limits can all create variability in coverage from insurance carrier to insurance carrier. And so as we look at parity, making sure that those quantitative and non-quantitative limits do not produce significant barriers for individuals to being able to access care. Sometimes this means that we have fail-first options that are required within policy, meaning that individuals have to fail some less expensive options for treatment before they can be considered eligible for necessary services. Comprehensive medication coverage is also important. We know the success of long-acting injectable medications and other FDA-approved medications in helping to maintain individuals in many different behavioral health conditions. And while they can be more expensive, overall do result in significant savings to the system. Expanding coverage for behavioral health providers so they are able to work in primary care and medical settings. We know that when we can provide behavioral health services within our FQHCs and other primary care and medical settings, we can successfully implement things like screening, brief intervention, and referral to treatment, detecting individuals who are at risk for developing behavioral health conditions before those behavioral health conditions meet criteria for a diagnosis and need higher levels of care. We also have the opportunity to create specialty care for behavioral health services in Medicaid, specifically using the levers of waivers and state plan amendments, including prevention and early intervention services and coverage services, using a chronic disease model for care for those individuals who have serious and persistent mental illness or who will require ongoing treatment and support as they work towards recovery, as well as looking at the need for habilitative services and supports for individuals with disabilities as it relates to behavioral health care. And of course, something that this committee and other committees have heard over and over again is to ensure competitive compensation rates for those individuals who are enrolled in healthcare delivery services. Because while we may have coverage, if we do not have providers that are ready, willing, and able to treat those individuals that are covered under that plan, we do run into accessibility issues. So some additional behavioral health accessibility considerations is establishing network adequacy standards. We know that sometimes having narrow networks really does not allow an individual to access the care when and where they need it in their community. It also can limit the number of available providers. And there is some new research coming out where they have been looking at the number of providers that are enrolled under a healthcare service plan and those that are actively taking patients or seeing patients under that healthcare delivery service system. And what we see is there is also a mismatch there. While there may be more providers that are enrolled, relatively fewer of them are actually providing services under that eligibility category. Telehealth coverage, certainly we've seen an expanse of telehealth coverage during COVID, but we also have to be mindful as we look to leveraging telehealth coverage because it can lead to even furthering disparities in access to care, specifically in geographic areas that lack broadband access, and potentially alleviating the opportunity for people to have choice on whether or not they would like to see a provider in person versus being required to see that provider via telehealth coverage. Establishing networks of care and systems of care can assist in accessibility of services because instead of having fragmented services, we see those services woven together in a fabric, which allows for transitions of care and sometimes multiple providers being able to work with an individual simultaneously towards a comprehensive care plan. Assisting in developing behavioral health equity standards and ensuring that we are addressing social determinants of health can also identify what some of those barriers are for individuals accessing care and making sure that we can address those barriers as facilitators to being able to access care. Also offering the expansion of access points for behavioral health screening across our healthcare system. Primary healthcare and healthcare integration. Also navigation to care supports. You've heard just prior to this presentation, a presentation on community health workers. Adding community health workers as well as case managers and peers allows providers who are licensed in behavioral health to work to the top of their scope, while also ensuring that we have a network of other providers like community health workers that can help people navigate to the care that they need. Specialty behavioral health services, including services for children and adults with intellectual and developmental disabilities and behavioral health issues, is important and is a largely missing element of our workforce, as well as ensuring have the opportunity to be educated in things like mental health first aid, psychological first aid, and suicide prevention. This can add to the natural supports and an extender of the behavioral health workforce by ensuring that compassionate community members have the tools that they need to be able to identify and provide some support and intervention and navigation to care for individuals who are struggling with behavioral health issues. Timeliness is another factor, another one of those components. And so some timeliness issues to consider, establishing wait time standards for healthcare plans. California and a couple of other states have moved to doing this because again, you may have coverage and that service is technically available, but the wait time that you have before you can access that service is far too great, specifically for individuals who have very acute care needs. We can also look to require health plans to clearly define time and distance standards for behavioral health levels of care, and describe policies and processes for accessing in-network and out-of-network providers. Tracking and evaluating wait times for care and wait lists for services is incredibly important to understand how people are moving through the system and how quickly they can access the care that they are seeking. We do not, for example, have an ongoing ability to manage and monitor the number of youth that are waiting in an emergency room for a higher level of care. So being able to have insight into where and when people are waiting and for how long for what services can help us also engineer a system that can be more responsive to their needs. Requiring behavioral health crisis coverage across payers is also one policy lever that can be considered. Knowing that individuals being able to access care when and where they need it is important. Investing in service capacity, prioritizing geographic regions without access to care and beginning to build infrastructure there, as well as providing real-time information on service availability by providers. And finally, I'll leave you with some points as it relates to workforce. So when we talk about workforce, again, we're talking about workforce adequacy that ensures there's sufficient access to capable, qualified, and culturally competent providers throughout the behavioral health system. Some considerations is to facilitate the integration of behavioral health providers in primary care and medical settings and remove any barriers there are for them to practice in integrated settings. Expand providers that are trained in community mental health services. While it's great that we have providers that are trained to go into private practice, working in community mental health settings is unique and does require some additional skills as well as experience. Again, recognizing the need for specialty behavioral health services, providing opportunities for behavioral health providers to work to their top of their scope, including expanding eligibility for community health workers and peers to help support navigation to care, and supporting caregivers and families and natural supports to ensure that they have the support that they need to continue to help the individuals that they may need under their care. When we talk about workforce, we also talk about workforce pipelines. This often begins in K through 12 education and moves all the way through an individual accessing the education, training, and experience necessary to become a licensed or certified provider in the state, as well as then maintaining that licensure or certification as they continue on in the workforce. So opportunities to evaluate state standards for licensing and ensure that we have adequate access to education, training, and experience to help meet those standards. Establishing opportunities from practicum to fellowships for the workforce experience. Providing mentoring and competency development support. Working to retain and recruit qualified providers in our networks. Developing incentive programs as well as value-based reimbursement strategies, helping to increase diversity within our behavioral health professions and increasing culturally and linguistically appropriate services, recognizing burnout and promoting healthy workplaces, and continuing to help individuals grow competencies. So some core long-term strategies include leveraging the National Health Service Corps. HRSA has worked very hard to expand availability of National Health Service Corps. What Nevada has not done yet is to really lean into the availability and work with providers who work in those behavioral health workforce shortage areas to qualify as a National Health Service Corps site where they can then recruit licensed providers to be able to be eligible for loan repayment, as well as establishing some loan repayment programs specific to the state, assisting in building that pipeline to professions through K through 12 education, leveraging interstate compacts for specific behavioral health and healthcare professions, and establish, I'm not exactly sure what this one was supposed to say. I think it's established transparency for licensing. So with that, I will take questions, Chair Peters.
Thank you so much, Dr. Woodard. Committee members, do we have any questions regarding this presentation item? I don't see any here. Do we have any in Las Vegas? Or anyone virtual? Doesn't seem like we have any, so thank you so much, Dr. Woodard, for your time. I greatly appreciate it,
Thank you.
especially the workforce piece. I think that's very important, and we've noticed that even with the duration of the COVID-19 pandemic. So thank you so much. Let's go ahead and move on to the next agenda item, which is a presentation, agenda item 7, presentation on vaccine preventable diseases and vaccination coverage status in Nevada. We have 2 presenters for this agenda item. We have Kyle Devine, who is the Health Bureau Chief in Child, Family, and Community Wellness, and we have Dr. Duckworth, who is the Executive Director of Immunize Nevada. So please proceed when you both are ready.
Thank you, Vice Chair DeMonte and Chair Peters and committee members. My name is Kyle Devine, and I am the Chief for the Bureau of Child, Family, and Community Wellness. Today, I'm going to briefly go over the Nevada State Immunization Program, vaccine preventative diseases, some data, provide challenges, as well as some best practices and innovative ideas.
Apologies, this is broadcast. We're currently seeing your slides and your notes. If you could go up to display settings and switch the view, we will be able to see the slide full screen. You just hit duplicate slides. Go to start the slideshow from the beginning. There's a little icon in the orange bar. Or you can go there too. We are currently just seeing the slide. If you go to the from current slide icon at the top of the screen, we should be able to see everything.
Is that working now?
Unfortunately, we're still just seeing the slide. Can you go to the top orange bar, right where your arrow is, and just click on that icon for me? Start from beginning. I'm going to end your screen share, and then I'll have you restart it here in about 10 seconds, okay?
Thank you.
That may fix it. So now if you can go to screen share in your Zoom, and then select the PowerPoint presentation rather than a screen. There you go. And then if we're currently seeing the slides, so if you go to the view, and go from beginning. And now go up to where it says display settings, which is right next to show taskbar, and do swap presenter view and slideshow. There we go. We can see the slides. Thank you so much.
My apologies, committee members. I worked through this with our IT this morning. I guess we set it up incorrectly. So to resume my presentation, the state immunization program works with and supports Nevada's local health districts, private providers, hospitals, schools, and community agencies. So we really take on a supportive role for the most part. However, we also do administer public funded vaccine programs as well. The support includes ensuring equitable vaccination access, management of the state immunization information system, which we call WebIZ, and management of publicly funded vaccine programs as previously mentioned. The WebIZ system is a confidential population-based database that records all immunizations administered by the providers. As of 2010, all vaccinating providers in Nevada are required by law to report into our WebIZ platform. Currently, we show that we have 1,900 providers that are representing 3,000 clinic locations within the system. Not only does WebIZ serve as a place to store immunization data, it supports a wide variety of immunization program activities, including assessment of vaccination coverage amongst our populations and publicly funded vaccines. As a result of the response to the pandemic, Nevada was able to successfully implement a QR code technology in 2021, which allows a person to access their COVID records by scanning a QR code. As a result, we are currently exploring the ability to implement a digital vaccine report card that can also use a QR code for all other vaccines that people have access to. In addition, it's as another result of the pandemic, there were some positives that came out of the pandemic. Nevada was one of the first states to successfully implement state data sharing. It is now possible for Nevada residents to have their doctor through the interface within WebIZ to access records in other states, which allows them to consolidate the immunization records for their patients. Currently, however, Nevada can share data with only 7 other states, as most other states' technologies need to be upgraded in order to take advantage of this system. So when we look at vaccine preventable diseases, the state of Nevada, we follow the Advisory Committee on Immunization Practices recommendations on the vaccines that we utilize. The Advisory Committee on Immunization Practices is a body of experts who make recommendations to the Center for Disease Control and Prevention, who then provide guidance and recommendations to all providers. So here's a list of the current ACIP vaccine preventable diseases. In your presentation at the very end was included definitions of each one of these for your reference. So for our schools, existing law actually provides broad authority right now for the Board of Health to create policy governing vaccine administration in the state. What you are seeing right now is a list of the current vaccines that are required by current state law in order for children to enroll into schools. I do want to note that the law provides for religious exemptions and exemptions for certain medical conditions. So some of the data for our childhood immunization, what this shows is the recommended 7 series vaccines, which are all those vaccines recommended for children to receive prior to the age of 24 months. So this figure shows the childhood 7 series vaccination rates in Nevada for the past 3 years. We did see an impact, what we believe is an impact from COVID, as between 2020 and 21, there was a reduction in the number or percentage of children receiving those vaccinations. This is another depiction of that information. This figure shows the breakdown of the 7 series vaccination rates by race and ethnicity. It's interesting to see that, and kind of concerning, that for the American Indian and Alaskan Native population, that there was a drastic reduction in vaccinations during this last year. Yet it's also interesting to see that for the Black population, there's actually an increase. So looking at this graph here, it tells you the percent of increase or decrease in the vaccination rates. And as you can see here, the American Indian and Alaskan Native population shows the largest decrease for infants at approximately 38%. And then once again, in the Black population, they saw a small rise in approximately 7% of children receiving the Series 7 vaccinations. So we have vaccinations recommended for our adolescent population as well. These are the recommended vaccinations for adolescents. For this analysis, 13 to 17-year-olds were included. When you look at the men ACWY, which is meningitis, there are new policies were put in place that now require children entering, or adolescents entering the 12th grade to be vaccinated for meningitis. So this is showing you the rates of the 13 to 17-year-olds with at least 1 dose of the HPV, meningitis, and Tdap vaccines. Unlike the 7 series childhood vaccines, this population had an increase from 2018 to 2021 for HPV and meningitis, but a decrease in Tdap vaccinations. Looking at it closer by race and ethnicity, you can see that all had an initial decrease, but most rebounded, with the exception, once again, of the American Indian, Alaskan Native population. The Black and Hispanic teens have higher vaccination initiation rates for all the vaccines than any of the other races or ethnicities. And HPV vaccinations is the lowest amongst Asian Pacific Islanders and white teens. This figure here shows the current meningitis vaccine rates amongst 16 to 17-year-olds by county. As you can see, Elko County is doing very well, and the one with the lowest rate, I believe, is White Pine County. According to the National Center for Immunization and Respiratory Disease National Immunization Survey, Nevada is ranked 34th with its vaccination rates for adolescents ages 13 to 17 years old. We are fairly close to the national average, but we do need to increase those rates further. We also believe that with the implementation of the mandatory meningitis vaccination prior to entering 12th grade, we should see an increase in these rates as well. And then we also deal with adult vaccinations. So here's a list or table of vaccinations that are available to adults in the state of Nevada. And once again, there are federal programs that can provide funding for adults to get these vaccines for those without a payer source. So looking at some of the most common vaccines for adults, looking at flu, pneumonia, and Tdap, as well as the shingles vaccines, which is Zoster. These are the current rates for adults in our state. The need for vaccines continues in adulthood, but it has its own set of barriers to uptake, including limited health care and low awareness among adults about recommended adult vaccines. Additionally, for Medicare clients, they have to visit multiple locations often to receive vaccines, as some vaccines are covered under Part B and others are covered under Part D. So this may also be another barrier in adults having to go to multiple locations in order to receive the vaccines. So here's some brief COVID data. Just the current data shows that we are somewhat flattening out at 60% of the population in Nevada having completed and in some cases completed and having booster doses are at 60% in the state. Progress in COVID vaccines from December 2020 to date, the uptake has leveled off, as I showed previously. In contrast to the childhood vaccine rates, and I find this very interesting, the American Indian and Alaskan Native population has the highest completion rates of any race or ethnicity. The COVID vaccination initiated, completed, and boosted by age is defined here. These are the ways that we commonly, let me go to, where am I? I think okay, let me move on to the outbreak response. In general, outbreak responses, and we have outbreaks every year in various jurisdictions, whether it be for hepatitis A, pertussis, or other communicable diseases. For a regular outbreak, the local health authority or the local jurisdiction takes the lead. Once again, the state immunization program only provides support. A lot of times we will provide support to make sure that vaccines are accessible. We provide technical assistance, and also in cases we can provide community and information to keep the public informed about the outbreak. Now, for the pandemic, more resources were needed, as this was a statewide outbreak. What we found is, at the local level, that relationships were very important in rolling out our response. Also, we determined that having a core group of staff available to provide technical assistance to the local health authorities was imperative in rolling out our response for COVID. We initially started with a group of 18 core immunization staff, but then had to bring on very quickly approximately 40 temporary staff. So lessons learned from the pandemic. As a response for the pandemic was statewide, more resources were needed to adequately support the local jurisdictions. As the state immunization program gained more personnel through the COVID response, we've learned that to have an adequate amount of core staff, as I indicated previously, that it is very important that we maintain that in order to respond to any future outbreaks. Partnerships are a must, and we saw a lot of partnerships strengthened through the response to COVID. Community-based organizations, local health authorities, the Board of Pharmacy, all stepped up to the plate, and we all strengthened our partnerships, which we are hoping will continue further. Having a centralized location that holds all pertinent information for an emergency response is imperative. We found that having a central place where data where everyone can go to get the same information at the same time was highly important. It also allowed us to manage getting accurate messaging out to the public. Lastly, we found that an emergency response, having a mobile partner is of great benefit. Having a mobile partner allows us to get to areas where vaccines may not regularly be offered, and allowed us to get to more vulnerable urban areas throughout the state, as well as a lot of the rural areas. So looking at best practices and innovative ideas. One best practice that is well documented is that having the ability to have data and a data system to direct our planning efforts. As indicated before, Nevada uses WebIZ, and its value lies in a large part on the data it receives and stores. As such, the quality of the data must be assessed and improved. A wealth of materials defining standards is regularly available, and we are continuing to try and actively pursue opportunities to implement skilled data quality staff to apply these practices. So once again, we need resources in order to accurately and better utilize the data that we have. Now, one of the practices that we see throughout the United States that shows an increase in vaccination rates is the use of a universal purchase program. So in a universal purchase program, vaccine is purchased by a state department. So that would be us, the Division of Public and Behavioral Health. And those vaccines are distributed to private practices, clinics, hospitals, and other providers to administer the vaccines. Vaccines, in this case, it allows the private provider to reduce some of the administrative burdens that is placed on the provider right now, as well as the need to purchase for themselves all of the required vaccines and have them on hand. With this model, one of the possibilities is to have the state purchase the vaccines at a cheaper rate because we can use the CDC's contract in order to purchase those vaccines, and then provide a monthly charge or a monthly fee to the third-party payers who support the practices that are administering the vaccines. In this way, the state can control the administrative burden. We can put the vaccines in the provider's hands so it's readily usable. and still utilizing third-party payers be able to pay for all the vaccines and administrative costs. So that is my presentation. I can answer questions now, or if you would rather I answer questions after Immunize Nevada does their presentation, I will remain available as well.
Thank you so much, Kyle. We'll go ahead and proceed to Dr. Duckworth to present her slide, and then after that, we'll go to questions from committee members. So Dr. Duckworth, please proceed.
Oh, this is Tara Narita. I'm actually going to be presenting on behalf of Immunize Nevada. So I will pull up my slides. Just give me 1 second. Okay. Is everyone able to see? Is everyone able to see the slides here? All right.
Yes, please proceed.
Good morning. Thank you. Good morning, Chair Peters and Assembly members. My name is Tara Narita, and I'm the Community Impact Director at Immunize Nevada. I'll be presenting on behalf of our organization. And just a quick overview of Immunize Nevada. Immunize Nevada connects Nevada's communities with information and resources to getting people vaccinated. And we do this through the completion of education, outreach, communications, and advocacy. So through our work in the community, we have identified some of the major issues that we have seen that impact vaccine preventable diseases and negatively impact the vaccine uptake, which overall affect the health of Nevadans. So one of the issues that we have identified is vaccine equity and access to healthcare. In Nevada, socially vulnerable populations have had limited access to vaccines, and the COVID-19 pandemic has exacerbated this issue to show that people who may not have vehicles, have disabilities, or limited English proficiency, for example, are not easily able to access vaccines. And because of this, the Nevada Vaccine Equity Collaborative was created to promote equitable distribution of the COVID-19 vaccine, which is still the main focus, but now also includes other routine vaccines for people to continue to stay up to date. The pandemic has exacerbated the problem of health equity and access to vaccines, especially for routine immunizations. Through the Nevada Vaccine Equity Collaborative, we are hoping to continue communications and outreach to ensure that those socially vulnerable priority areas are identified and have culturally and linguistically appropriate messaging for vaccine promotion, as well as developing equitable vaccine distribution plans of vaccines that may result up in pop-up vaccination sites to address this issue. And this has been clearly identified when we hear, since our community health worker team goes out into the community to set up these pop-up vaccination clinics, we hear when people get vaccinated that they either had these resources that they finally understand because it's in their native language, or they're able to read and address these and have their concerns addressed about the vaccines. Another thing we've seen is that people have identified that they get vaccinated when clinics are right outside their door or easy to access for them to be able to get vaccinated. And this leads me to my second point, is that another issue is that the provider gaps and shortages, which have added to the issues as to why people have limited access to vaccines. There has been a struggle with getting providers to enroll in administering vaccines, including the COVID-19 vaccine. Additionally, there are limited providers that are registered to be a part of the Vaccines for Children program, or VFC, as mentioned earlier, which is a program that provides vaccines at little to no cost for anyone younger than 19 and are either uninsured, underinsured, enrolled in Medicaid or Nevada Checkup, or are American, Indian, or Alaskan Native. Although these providers may get the actual vaccine itself for free, providers must provide the supplies and staffing to administer the vaccines out of pocket. So because of these additional costs, they may charge a small administration fee for these vaccines, but must not turn away any patient if the patient is unable to pay. And when this happens, providers must absorb the costs. This is why there are limited VFC providers, leaving the only options for underserved and socially vulnerable populations to get vaccinated at health districts and federally qualified health centers. By getting more providers on board with public health and prioritizing that vaccines are a preventable effort to protecting the community, we can increase enrollment and increase more vaccine access points to be more available for all Nevadans. Additionally, some of these locations are unable to open up their practices all times of the day that are convenient for most people. So take Las Vegas, for example. Many parents and guardians work on the Las Vegas Strip at odd hours of the day and may have days off to take their children in to get vaccinated during times that providers' offices are not open. And this delays shot schedules and access to getting vaccinated. So when there's a provider shortage, clinics are unable to open up vaccination clinics during this time, causing parents to go without their child's vaccines until they are able to make an appointment that fits everyone's schedules. And lastly, this leads to my last point, that Immunize Nevada has tried to expand the access to vaccines. And we have done this by working to onboard a community health worker team that has worked long hours to bridge the access gap to provide vaccines to Nevadans at locations and times that are outside of the normal work hours. We currently have 6 community health workers on staff, and it has been very beneficial to have them setting up these clinics for all Nevadans to get vaccinated. However, equitable access to vaccines can still be challenging because it does require a lot of training of our staff and a lot of manpower to be able to host these clinics with our vaccinating partners outside of normal office hours. These CHWs have certifications which can take up to 3 months to complete, plus our onboarding process of building the partnership to set up clinics in these socially vulnerable locations, building connections and trust among the communities to encourage vaccine uptake, attending clinics to shadow previous staff, and understanding the roles we play in these communities, and then actually setting up the clinic and staffing it themselves. This process to get the CHW members fully trained is long, but once they're ready, these CHWs have been able to set up clinics and get many vaccines into people's arms. So much so that in 2021, our CHW team hosted and partnered approximately 533 COVID-19 and flu vaccination clinics statewide, in which 23,518 COVID-19 vaccines and 4,165 flu vaccines were administered. And for a very small team of 8 CHWs at the time, this was amazing work. So luckily, we have had the funding to be able to support our CHWs in these efforts. And without them, we would not be able to set up as many clinics as we have had to address the access gap of getting people vaccinated. They have been able to address so many issues, such as setting up clinics during nights and weekends when it would be more well attended, going into communities that are unable to be vaccinated in a provider's office or pharmacy, and helping patients feel heard and comfortable when addressing any vaccine hesitancy issues that may arise. And it's because of our community health worker team that we have been able to expand access to vaccines across the state, which is why I strongly advocate for their work. So that's the issues that we have identified at Immunize Nevada. Thank you for your time, and I will now open it up for questions.
Thank you so much, Ms. Narita and Kyle Devine, of course, for your presentations. Let's go with questions. So I'll start us off. Perhaps this is more for Kyle. Can you elaborate more? For these 2 questions, I'm looking at the Nevada school required vaccines. Can you elaborate on states that have added the HPV vaccine as a requirement and what that legislation looks like nationally to increase HPV vaccine uptake? Is there a trend that you see nationally on this?
Thank you for the question. That is not information that I have right now, so I will have to look that up and get it back to you.
Yep, that would be greatly appreciated. And then my follow-up question would be, perhaps it could be either for Immunize Nevada or for you, Kyle. There has been, my understanding is in national conversations, there's always a consideration of, do we move back the required vaccines to earlier stages or earlier ages? Is that something that has come up in your conversations statewide, or are there modifications that we have to make to the current vaccines to improve access, or outside of the proposals that you guys presented, is there anything else that we should be considering?
Kyle Devine for the record. I have not heard anything in the state or any proposals to make those adjustments. Doesn't mean those conversations may not be going on nationally. However, we have not been looking at those within our state.
Great, thank you so much, sir. Anyone from let's go to Assemblywoman Titus.
Thank you, Mr. Co-Chair. I have a number of questions. First, for Mr. Devine, you mentioned on one of your slides that 60% of the folks have been vaccinated now for, I believe, the COVID. That's our rate. And I'm just wondering, do you have a percent on people who want to be vaccinated that aren't? Or have we reached that nexus now of everybody who wants that COVID vaccine has been able to receive it?
Kyle Devine for the record. When it comes to the COVID vaccine, we do not collect the data on the people who want it, who can't get it. So I don't have that information at hand. What we're seeing in the data with the uptake of the vaccine is has really stabilized. So my assumption is, at least currently, those who, or the majority of those who want the vaccine have reached out and received the vaccine. There are those populations who may not have had access, and we are currently trying to look at those populations to identify them and see what measures we can put in place to make sure that they do have access.
So
immunize.
I'm going to follow up a little bit more. I'm sorry to interrupt you, but that whole access, I have questions regarding access for both of you, actually. During the pandemic, and we reached out to the Walmarts, the CVS pharmacies, all the different pharmacies that are out there, Walgreens, et cetera, and we know pharmacists can administer vaccines. Why are we going to continue that process? Because seems like everybody goes shopping, everybody has a local store that they go to. Are we going to continue that collaboration with them? And because, there's always, well, go see your provider. Well, people can't get into providers, and that's really that's the block half the time. Are you looking at that collaboration with the local stores that have pharmacists to be able to have them administer these vaccines still? And then that seems to me like it would help with the after hours folks, especially the workers at nighttime that get off at different hours, et cetera. Are we going to continue that collaboration?
Kyle Devine for the record. One of the biggest and best relationships that we developed through the COVID response was with the Board of Pharmacy. And we do intend to continue that work and continue to work with the pharmacies for the COVID vaccinations. So that is something that we are projecting to continue in the future.
But not with, say, the school vaccines, et cetera, the childhood vaccines? Because
Kyle Devine.
I would say that's one of the biggest things that you're looking for solutions would be to expand what they could get at the pharmacy as opposed to having to go see that provider. As a provider, a family practice doctor for literally decades and decades, when I started practice, I received state vaccines in my office that I could give to those who were uninsured or on Medicaid. And ultimately, I had to stop doing that because it became a nightmare for those that were insured, and I had to keep those vaccines separated, couldn't get reimbursed for administration costs when I would administer the vaccine, nor could I get reimbursed from insurance companies when I gave to somebody who had insurance, and the insurance company would pay me less than what I paid for that vaccine. So it became literally a nightmare. So I stopped doing vaccines in my office because of reimbursement issues and what it cost me. So, I'm seeing that, and then you both, I believe, have stated that you have these vaccines and the state has purchased vaccines and you're recommending doing that federal buy program, but it's just not that simple when you're asking the provider to administer these things and it costs them money and time when they could see a patient that maybe they could get reimbursed for. So I'm just concerned about where your thought processes are being dependent on the providers and not looking at that, expanding the collaboration, say with the pharmacists, with the stores that have that access, which we did and did greatly with the COVID vaccine. So if you learn anything, it would seem to me like you should expand who has availability to give these vaccines. Are you looking at any of that right now?
Mr. Vice Chair, through you to Assemblywoman Titus, you bring up some very good points, and I do think exploring the relationship further with the pharmacists on some of these other vaccines has merit, and is something that we can look into moving forward. As far as a lot of the barriers that you highlighted, moving to a universal purchase of vaccines would allow the state to actually purchase those vaccines, which would take a lot of the burdens that you highlighted away from the providers. So that is a direction that we would possibly like to go. If the policies and the mechanisms can be put in place to where the state could then collect those fees and money from the insurance companies, and therefore the provider, they just have to worry about providing the vaccine to their clients and not where they're getting reimbursed from.
Could I add another question? Sorry to tie this up, but does the state have capacity to store these vaccines? One of the issues, certainly initially with the COVID vaccine, required frozen vaccines. Some of these vaccines that we still do are frozen, and I'm just wondering what capacity the state has if they were to purchase these vaccines.
Kyle Devine for the record. The state does have some limited capacity to store vaccines. Under this model, the vaccines would actually be delivered to the enrolled providers who have the equipment in order to store the vaccine themselves. So the vaccines would not necessarily come to the state first and then go to the provider. It's the state would be purchasing the vaccines, they would go to the provider, and the state would be reimbursed or obtain the funding through a monthly fee for those vaccines paid by third-party payers.
And sorry, Coach here, for more questions. Having lived this dramatically in my career on these vaccines, do you know in these federal programs and purchasing, do they also negotiate the returning the vaccines that have expired and how that you recycle these things to make sure that you're not having them sit in offices and then they expire, and does the companies take them back? Have you gotten into any details of that nature?
Once again, Kyle Devine for the record. Yes, we keep track of all that information. That is one of the things that utilizing WebIZ allows us to do. So we actively monitor situations where vaccine may expire and then work with providers, work with the pharmacy representatives and everyone to exchange those or to make sure that the vaccine stock is always current.
And last question, I promise. Is it current now that all electronic medical records have the interface with WebIZ? Because that was one of the other hurdles that we went through when we're trying to administer these vaccines, was that interface to get onto WebIZ through our electronic medical records. Are they all communicating now?
Kyle Devine for the record. That is still a barrier, many of the electronic health record systems have not employed the technology to be able to be interoperable with WebIZ. The mechanism through which we are now able to access other states' information, that provides the technology to do so. So we just need the electronic health records technology to be able to interface with that system. So that is still a barrier.
Has the state offered any reimbursement for providers to sign on? Because the ones that we use, it was going to cost literally thousands of dollars, almost $20,000 to get that interface through our EMR. And that's a huge barrier, is the cost of not only do we not get reimbursed for doing the shots, it was going to cost us a lot of money to be able to interface with that WebIZ. Has that been resolved?
Kyle Devine for the record. The technology that we're using right now to access those other state records was actually implemented by the CDC during COVID. We haven't provided incentives or anything for providers at this time, but that is something that we want to look into because we know that interoperability is very important for us here at the state, and we want to make that as easy as possible for the enrolled providers.
Great. I'll look forward to seeing how that progresses. Thank you, Chair, for the questions.
And Assemblywoman Titus, just to let you know, Eric Robbins has a clarification for you on the discussion between the pharmacists and the physicians.
Okay, so I just wanted to note that the Board of Pharmacy has adopted regulations and concerning the administration of immunizations by pharmacists, and it's the relevant provision is NAC 639.2971, which allows a physician and a pharmacist to establish a written protocol which authorizes the pharmacist to administer immunizations. So.
Great, thank you. I actually had that with my local pharmacists in town where I signed them off so they could administer that. And that was already pre-existing before COVID. We could do that. But the question that I had was this association with the state providing the vaccines to these, because when the pharmacist would give a vaccine, say, I took my not chickenpox, but oh my God, zoster vaccine through the pharmacist, but I had to purchase it, right? And so there's a difference there. So expanding what the pharmacists can do to expand access, they can already give these vaccines, but the pharmacist doesn't want to buy these vaccines either. So there's lots of obstacles with this. Thank you. Thank you.
Yeah, thank you so much, Assemblywoman. Anyone in Las Vegas that has any questions? I believe Assemblywoman Gorlo has questions, so please proceed.
Thank you, Vice Chair. I had a quick question on slide 18, which was talk about the county rates of meningococcal, I believe. And it was mentioned that White Pines had the lowest. Are you seeing those trends in the same with other vaccines? And if so, why might that be happening? Thank you.
Kyle Devine for the record. Those rates are somewhat comparable to the other two vaccines for the adolescent population. So there are probably multiple reasons for that. One that we need to dig into is access. We also know that having, champions within communities, which I believe ELCO has a local champion for getting those vaccines administered, has a very big benefit. So really moving forward, we need to research that further. We need to create those partnerships with those various communities in order to see how we can improve those rates.
Thank you very much.
Thank you. Any other questions from Las Vegas? I don't think I see any, and any virtual as well. So let's go ahead and close this agenda item. Great, thank you so much for the presentation. Let's go ahead and move on to our next agenda item, which is agenda item 8, the overview of public health prevention and wellness initiatives and programs to address non-communicable chronic diseases. We have 4 presentations under this agenda item, and we will first hear an overview of the chronic disease program and data and the 2022 Nevada Needs Assessment, which will be followed by a presentation on community-based obesity prevention and wellness promotion. We will also review the health workforce supply and demand and its implications for chronic disease prevention and treatment. And then finally, we will hear about policy considerations for chronic disease prevention. Given that we are getting closer to our lunchtime period, I might cut us in half with these presentations and break for a little bit, but let's go ahead and proceed with our first one. So an overview of chronic disease data program and the 2022 Nevada Needs Assessment. For this presentation item, we have Lily Helzer, who is the Section Manager of Chronic Disease Prevention and Health Promotion. So please proceed when you are ready.
Good morning, committee. My name is Lily Helzer, and I am the Chronic Disease Prevention and Health Promotion Section Manager with the Division of Public and Behavioral Health. Chronic disease accounts for 7 of the 10 top causes of premature death for Nevadans. Treating people with chronic disease accounts for the majority of our nation's healthcare cost, nearly $4.1 trillion annually. These are the cross-cutting areas that guide our work at CDPHP, a focus on wellness to include the integration of mental health, and a focus on health equity. This presentation will focus largely on public health efforts to prevent and control chronic disease, so it's important to recognize there are differences in prevention reach. Primary prevention describes true disease prevention, while secondary and tertiary prevention describe disease control. While there has been great success in primary prevention and public health over the last 150 years, especially in tobacco control efforts, public health still largely focuses on secondary and tertiary prevention. This is due to numerous factors, including funding requirements and a focus on clinical care over social determinants of health, lifestyle change focus. Common risk factors that can reduce through primary prevention efforts include physical activity, nutrition, and smoking status. While heart disease and cancer are consistently number 1 and 2 among all races and ethnicities, many minority communities experience additional disparate disease burdens. For example, among Blacks, American Indians, Alaskan Natives, and Asian Americans, diabetes is the fourth cause of death overall, not the 5th as indicated on this table. For Hispanics, diabetes is the 3rd cause of death overall. Again, heart disease and cancer consistently rank among the highest deaths in Nevada. Under previous years before COVID-19, trends were stable among chronic lower respiratory disease, stroke, and non-transport accidents. This means that prior to COVID-19, 4 of the leading causes of death were chronic conditions only upended by the pandemic. Trends have remained largely stable. Decreases in respiratory disease and stroke indicated on this graph beginning in 2019 may have more to do with people dying from COVID sooner than they were able to pass from the diseases they were impacted by. It'll take a longer time to study this. Early reductions in chronic conditions have been evident as tobacco control policies became commonplace and smoking behavior was reduced. However, these early decreases became less evident as other risk factors, such as lack of physical activity and poor nutrition, increased. This is not to indicate that there is a need for to move on from tobacco control efforts. Sustaining those efforts is imperative to continuing decreased trends. I understand the committee previously heard a presentation on obesity, so I'll only spend a short time in this risk factor area. It is important to note that while Nevada remains under the national average for both adult and childhood obesity rates, the rate is increasing. Youth obesity in Nevada increased from 11.4% in 2013 to over 12% in 2019. Regarding cost, in 2021, net payments by Medicaid to providers for cardiovascular disease totaled over $168 million. For cancer, payments exceeded $96 million. Though Medicaid recipients represent only 20% of the Nevada population, this data gives us perspective on the burden of chronic disease, not only for individuals, but for the state as well. The magnitude of managing chronic disease in Nevada is significant. Any impact we can make contributing to the reduction of chronic disease will not only decrease the financial burden to the state, but also improve the lives of Nevada individuals and their families. To address risk factors, disparities in risk factor status must be acknowledged. Overall, Nevada ranks 39th as the most obese state and is continuing to trend upward. Nevada adults of all race ethnicities indicate lower physical activity than the national average. However, American Indian, Alaska Native, and Hispanic children have the highest rates of obesity compared to other races and ethnicities in the state. Smoking status has decreased among Nevada adults, reflecting the national trend. However, a significant percentage of Nevada adults of all race ethnicities continue to report smoking. I will note smoking status among adults has decreased, but it is important to note the significant increase in electronic vaping behavior among Nevada youth, reflecting the national trend known as the youth vaping epidemic. Statewide, 1 in 4 kids under 18 have tried or are currently using an electronic vape product. So these are the programs that Nevada currently houses under chronic disease prevention and control, and the areas for chronic disease that we are able to address. Looking a little bit at funding, pardon me, CDPHP receives just over $16 million to support the programs in the previous slide. Of that, a little over 9.7 is received from federal grant awards, while 6.5 is received from state funds specifically to support the Women's Health Connection program for breast and cervical screening, youth prevention, youth vaping prevention efforts, tobacco prevention and cessation, and food insecurity. Current disease-specific funds are restrictive and cannot be utilized for comprehensive surveillance or the development of robust wellness programs to address primary prevention and risk factor reduction outside of those already dedicated to tobacco prevention and vaping control. Evidence indicates that implementing comprehensive programs that address risk factors will improve health outcomes related to chronic disease, as well as improve overall wellness and quality of life. So moving on to the 2022 needs assessment. Over 50 partners in public health throughout the state participated in key informant interviews to develop the needs assessment. Results were organized into 2 categories: those needs that were evident in the community by Nevadans to improve health, and the needs of partners to help serve the community. This first slide represents community needs. Partners indicated the community is largely challenged to successfully access available services. This includes physical challenges to access, such as transportation, as well as economic challenges. Economic challenges are both related to the cost of care and the secondary cost of care, such as missed wages for appointments or inability to access and afford childcare to attend appointments. Health equity and equitable services was identified as a need. Partners also identified a need to focus on prevention in order to truly impact health and quality of care. Partners noted this would require a focus on primary prevention and social determinants of health, as well as integration with mental and behavioral health to support true comprehensive wellness. And specific challenges were noted in serving rural and frontier populations, such as distances to services and the additional impact of provider service shortages in rural areas. Rural communities also face a disproportionate burden of disease, resulting in further challenges to accessing care and resources. Partners participating in the needs assessment also noted specific challenges experienced in Nevada's tribal communities. Nevada's tribal communities experience higher rates of obesity and lower access to nutritious food security than other Nevada communities. Overall, the following resources were suggested for Nevada's tribal communities: infrastructure and capacity related to public health, improved insurance systems and access to providers, technical assistance for grant writing capacity to help tribes access resources for themselves, and providing education in ways that the tribe understands and creates clear links to public health. The second set of needs identified represent those needs partners have to deliver services to Nevada communities. The first and largest need was for flexible funding that can be used to address prevention and wellness. Additionally, workforce capacity, especially the provider shortage, has been a substantial challenge. Providers also noted challenges with work within the state system, and partners also indicated a need to improve forums for statewide collaboration and tools to support additional information and data sharing. In summary, evidence indicates primary prevention through addressing social determinants of health and risk factors such as nutrition, physical activity, and smoking status will have the greatest impact in reducing the burden of chronic disease and improving quality of life. Thank you, and I will take questions at the discretion of the committee.
Thank you so much, Ms. Helzer. Committee members, any questions? None here in Carson City. Anyone in Las Vegas or online? Doesn't seem like we have any. So let's go ahead and thank you so much for your presentation, Ms. Helzer. Let's go ahead and move on to our next presentation, looking at community-based obesity prevention and wellness promotion. We have Dr. Stephen Shane from the Obesity Prevention Chair on the Nevada chapter of the American Academy of Pediatrics. So please proceed when you are ready.
All right.
Mr. Shane, you are on mute. We cannot hear you.
Okay. Can you hear me now? Good. Well, thank you for inviting me to speak today. It's definitely an honor and a pleasure to be able to do this. I'm a pediatrician in Reno. I work at Northern Nevada Hopes Clinic, and I'm the Obesity Prevention Chair for the Nevada chapter of the American Academy of Pediatrics. I'm also board certified in obesity medicine. And what I'd like to do today over the next few minutes is build on that nice data information that Lily Helzer just provided and make a case that there is a dire need for addressing obesity in our children and in our total population for that matter. And it's also I think a smart way to focus on overall wellness promotion, since really everything that we do to try to improve weight status and prevent obesity really helps us prevent a number of the other chronic diseases that we're already working on. And also I'd like to make a case that, the state, we need to recognize obesity as a disease and properly monitor it, which currently, I don't think we're doing enough in regard to that. So what I'd like to do first is talk about exactly what obesity is, because I think a lot of us just really don't appreciate that it's an actual disease process, not just a condition or a body type. Its true impact on us, not only medically, but economically. And then, just how pervasive this disease is in our population, and that we need to do something about it now. And then hopefully give you some good recommendations on policy changes that we can work on as a state to improve our population health. So first, to define obesity, it is actually a disease and defined as a disease process in 2013 by the American Academy of, or the American Medical Association. This is a definition from the Obesity Medical or Medicine Association, which I'm a member of. And you can see it's a pretty complex definition. So chronic, progressive, relapsing, treatable, but not curable, multifactorial neurobehavioral disease that causes many metabolic and also direct mechanical problems. So until we recognize obesity as an actual disease process, I don't think we're going to do it justice in regard to how concerned we need to be about it and to address prevention and treatment measures. So I'm just going to give you a quick patient scenario. This is an 11-year-old patient of mine. Change the name obviously for the sake of confidentiality, but this is Daniel, who I saw back in the spring, first time since prior to the beginning of the COVID pandemic. 30-pound weight gain in the 2 years since I had seen him last. Had developed severe obesity, prediabetes, obstructive sleep apnea, high cholesterol, high blood pressure, depression, anxiety, being teased and bullied at school. Also has fatty liver disease and some orthopedic complaints. So I think most of us would agree that if you didn't know this was an 11-year-old, you'd probably guess that this person was, 40, 50, 60 years of age. But this is an 11-year-old, not even in puberty yet. And some days in my clinical practice, I see multiple Daniels. So just very distressing to see young people like this. And also very, just makes me sad. And I just feel like we need to be doing better to help Daniels in our state, in this world. So this is a nice cartoon that gives us a good idea on just how obesity, and this cartoon is for childhood obesity, how it essentially affects all parts of our body, all organ systems, even the brain. It's associated with depression, headaches, anxiety, poor self-esteem, and obviously bullying, like I just mentioned with Daniel. If we were to include adult issues, it'd be pretty much the same, except we probably would add cancer. There's currently 13 types of cancer that are associated with obesity. Obesity may soon overtake tobacco as the #1 cause of cancer. And there's 4 other cancers that are currently being entertained as having a positive link with obesity. So just looking at this alone makes a good case on how focusing on obesity prevention can help us promote wellness in a global fashion and to prevent many of the chronic diseases like cardiovascular disease, diabetes, mental health illness, health issues in our population. This is a scary graphic from the CDC, and this is measured data that's provided every 2 years by the federal government. Unfortunately, the last data we have is from 2017-18. A lot of the data collected through the pandemic has been slow to be published. But the bottom line here, as you can see, for children from the 70s to 80s until the present, depending on the age group, younger ages on the bottom, older ages of kids on top in the light green. The prevalence of obesity has essentially tripled or quadrupled. And this is, holds true for adults as well. And then this graphic from the State of Childhood Obesity, which is a wonderful organization under the umbrella of the Robert Wood Johnson Foundation, has broken this down a little bit differently. And we can see children on the left, adults on the right. And you can see the 19.3% that I just showed you in another graphic. They did, the CDC did release data last fall when it was shown that from August 2019 to August 2020, just months into the pandemic, this number in children had already jumped up to 22.4%. So we're already, back in August of 2 years ago, we were already looking at over a 15% jump in that overall. So more than 1 in 5 kids with obesity. And you can see adults essentially is double that. And then you can see some ethnic and gender breakdown. So you can see in kids, unfortunately, Black girls and Hispanic boys have the highest prevalences. And you can see for Black women, already over half of Black women adults have obesity. Yeah, so I'm looking forward and not, because I think more current data with impact from the pandemic is going to look pretty disturbing. And this is just more detail on that interim data that the CDC released on children. What's important here is this slide shows that younger children, this was actually had an even greater impact. Essentially, the rate increase in body mass index in kids doubled during that first few months of the pandemic. Now I'm going to go over some state data. This is the Nevada Kindergarten Health Survey, which is done annually by the Nevada Institute of Children's Research and Policy out of UNLV School of Public Health, directed by Amanda Habush-Deloy. And they do a great job of providing self-report data from parents on children entering kindergarten each year throughout our state. So it's a great sample of Clark County, Washoe County in the rural areas. And you can see already in these young kids who are 4 or 5 years of age already have a significant proportion of being overweight or having obesity. And these are the kids that we need to be impacting at this age or earlier, because we know that by age 5 or 6, weight status is probably not going to change too much throughout the lifespan. So we really need to be making a difference in these kids probably before they're surveyed at this point. I do want to point out that this is self-reported data, which has some problems in regard to accuracy compared to measured data, but it is good self-reported data, and it provides us some trending, year to year, and how worried we need to be. This is some more data from the State of Childhood Obesity. I do want to mention this is a great resource for all of us to use to look at up-to-date national data and also state-specific data, and also ongoing policy work and policy recommendations for preventing childhood obesity. So if we look on the left here, 2 to 4 year olds participating in WIC, this is 11.7% is probably, if not the best, one of the best health metrics for the state of Nevada. So 51 is the best. We are 47th. And this is from 2018 data. So 11.7%. This is measured data. This shows us that the WIC program is effective, and actually nationally over the last decade. In 37 states, including Nevada, there's been a significant decrease in body mass index in this age group of kids. So this is a program we need to really work with. Some recommend, including the State of Childhood Obesity, expanding services of this program. And we need to do a good job as a state to make sure that we're appropriating funds and getting individuals who qualify for this service are participating. I think currently, with most recent data, only about half of the kids that qualify for WIC are actually getting those services. The next data in the middle and the right are self-reported data. So we have to take that with a grain of salt, so to speak. So for children's 10 to 17, 16%, so 21 out of 51, so not as good as the WIC participants. And then high school students, 12.3%. And I'll show you very shortly that this is probably very much underreports actual data when we measure high schoolers. So 39 out of 51. And these two have been trending upwards, just like adults that we just heard from the last speaker, from Lily Helzer. This is the most recent published data from Washoe County School District. So this is measured data. And you can see here in the purple in the pie chart on the left that those with obesity is 18.8%. So you can see, and when we know that as you get older, as a child, your prevalence of obesity goes up. So high schoolers usually have the highest prevalence of obesity. And we just saw that 12.7% self-reported. And this overall number of 18.8% for 4th, 7th, and 10th graders shows us that self-reported data probably doesn't give us the true picture. Also, I wanted to point it out before we leave this slide, the incredible difference between Title I schools in the red on this bar graph on the right compared with non-Title I schools. So just pointing out the differences we see in socioeconomic status, which also equates with certain ethnicities. And obviously this is not only holds true for our state, but for our country. So looking at the impact of this disease, the most recent report from the Milken Institute, their Weighing Down America report in 2020, estimates that $1.4 trillion dollars in medical and also social cost for adults is realized each year from obesity. And this continues to trend upwards, a very significant portion of our GDP. It's estimated by the State of Childhood Obesity, the Robert Woods Johnson Foundation, $14 billion in direct healthcare costs for children. And then this disease directly causes 320,000 deaths annually. A very disturbing report 5 years ago projected that kids at that point in time, when they reached 35 years of age, over half would have obesity. And I'm sure if this same modeling study was done today, it would look much worse, considering what has occurred with the COVID pandemic. And as I mentioned a couple slides back with the kindergarten health survey, we really need to be impacting kids early, and we're probably even perinatally, infants, toddlers, before they get into kindergarten and first grade, because their weight status by that time is pretty much set. It's going to be unusual for a child who has obesity at age 5 or 6 to be able to move out of that weight status as they get older. So how do we get to this point? Obviously these photographs depict some common habits in our society today that have led to increased chronic disease burden as well as obesity, but it's more complicated than this. It's more than just sitting around on a bed or a couch playing video games and eating fast food and drinking soda. This is a more comprehensive breakdown of the factors that go into weight status in chronic disease. And we're learning more and more about genetics, which accounts for about 40 to 70%, or at least has some part in obesity. But obviously there's a lot of other factors, including mental health issues, food quality, food quantity, environment, how much physical activity you have, and so forth. So it's a complex process. And it's a biologic process, as I had mentioned. It's not a matter of willpower. And then obviously you throw in a number of factors that have been amplified during the pandemic, including disrupted family and school routines, sleep dysregulation, reduced physical activity, increased time on the screen, stress. Stress causes stress hormone increase, and this adversely affects metabolism and leads to weight gain. Food insecurity, increased mental health problems, and decreased healthcare access. So what can we do about this as a community, as a state? As we've already just discussed, obesity is a very complex issue. This is from the Milken Institute, other organizations such as the American Academy of Pediatrics, the State of Childhood Obesity, pretty much concurs with this perspective. And it's going to take solutions that are going to require complementary actions from federal and local authorities, as well as leaders in public and private sectors. So this is going to take healthcare, businesses, schools, daycares, after-school programs, and the community as a whole working together to make a real impact and really to make a true difference in chronic disease burden as well as childhood obesity. This is a very interesting study called the Healthy Community Study, which was published just 4 years ago. And this was looking at what communities do, how much and at what intensity they do in regard to trying to improve policies and environments for communities to improve weight status in young children. And this study was a big lift, and a lot of effort went into this study. 130 communities across the country were chosen, and purposely, very diverse communities, socially, economically, and with ethnic breakdowns, and looked at 10 years of data. And this was a lot of questionnaires, a lot of interviews, and also measured data. So measured heights and weights. So we have good body mass index data on the kids from these communities. And this top graph shows, and Basically, these were all scored depending on the reach of the policies, the strategy, and the intensity of these policies impacting communities and behaviors. And what you can see is over time, over this 10-year period, like most things, as time goes with practice, things get better. So these overall, the community scores, intensity scores, increased, as you can see in that average line, which is that darker line in the middle. And then the bottom graph shows that the better the programming, the more intense the policy scores for each of these communities, the more impact it had on improving weight. And it did so in a significant fashion. So just this goes to show us that working together in a multi-sector fashion, as I just mentioned from that Milken Institute report, can work, but it's a heavy lift. It takes a lot of work, a lot of people, and significant funding. So I'm just going to throw this up real quickly. I'm not going to go through all these, obviously, for the sake of time, but this is from the State of Childhood Obesity policy recommendations that this organization has earmarked. And, a lot of these are federal, a lot of them, some of them are purely state, and obviously a lot of them are a combination of federal funding, working with state appropriation and administration. Again, I pointed out earlier that the WIC program has been very successful. One of the recommendations of this think tank is to expand services and also making sure that those who qualify get these services, because we know that it can work. I also know recently that the Finance Committee just approved for some gap funding for reducing food insecurity in our schools over the next year. So that's wonderful, with providing free school lunches for all over this next school year. So another good example of where state policy hopefully will make a difference in reducing chronic disease risk and obesity in our children. The American Academy of Pediatrics has a number of policy recommendations, including considering ways to reduce sugary drinks being consumed by our children. So considering excise taxes, looking at marketing, which the State of Childhood Obesity also recommends. There's research that shows that there's been a lot of preferential marketing towards certain ethnicities, such as Hispanics and Blacks. And ensure that our federal assistance food programs are providing healthful food and beverages and discouraging consumption of sugary drinks. Also, we need access to credible and also understandable nutritional information for families, making healthy beverages the default in a wide variety of settings, even fast food or restaurant settings. And in its healthcare settings, including hospitals, we need to be role models for the populations that we're taking care of. So a lot of good policy recommendations from good organizations that have done a lot of research in this arena. So I'm going to throw up here the most recent behavior that has been collected by the Youth Risk Behavioral Surveillance System that is done every 2 years by the CDC. For our state, the UNR, School of Public Health, contracts with the state to collect this data. And it gives us a nice snapshot every 2 years on how well healthy habits or behaviors, how prevalent they are in our populations. And this is in high schoolers, it's self-reported data. As you can see that underreported, self-reported BMI number that we talked about a few minutes ago. But I think this slide is more important, looking at the room for improvement in regard to impacting behaviors that we know that can help reduce chronic diseases such as cardiovascular disease, diabetes, and obesity. So eating sufficient amounts of fruit on a daily basis, as well as vegetables, quite abysmal, 12% and 5%. These have been trending downwards over the last 2 years. And I'm sure when we get data that includes experience through the pandemic, this may look worse. Excessive screen time, 60%, and then only about 1/5 of our high schoolers are getting the recommended amount of moderate physical activity every day. So 20%. And only about 1/3 did not have any soda for the 7 days prior to them taking this survey. So a lot of room for improvement in regard to healthy behaviors. In regard to multi-sector community prevention programs that I was alluding to in the Healthy Community Study, and getting back to that last slide in regard to healthy behaviors, the Maine Health Let's Go 5210 program is a wonderful program in the state of Maine that can help a community, a state, move the needle in regard to improving these behaviors. And I've been using the 5210 messaging for the last at least 7 years of my practice, knowing that it's easy to remember, it's very translatable into different languages, different cultures, ethnicities, educational levels. It makes sense, it's simple. And each of these numbers are associated with a behavior that we know can help reduce chronic diseases and improve weight status. So 5 or more fruits and vegetables each day, 2 hours or less of screen time, of recreational screen time, 1 hour or more of moderate physical activity, and 0 sugary drinks. And this is the puzzle cartoon that they like to use to show that this, again, requires all facets of the community working together to make a difference. So ideally, you want to improve environments and policies to make families and children have the easy choice be the healthy choice. And that's what this Let's Go program does, as well as other programs that are like this. And I should mention other states are using this program, other than Maine, for instance, Iowa, Hawaii, and municipalities such as Pittsburgh, Charlotte, North Carolina. Let's Go does this in the state of Maine by a very nice infrastructure. They have a spoken wheel infrastructure where they have a backbone main office in Portland, Maine. And then they have a number of regional coordinators that help implement, train, provide technical support to help schools in different parts of Maine, doctors' offices, daycares, promote that 5210 messaging and other healthy behaviors. This became a statewide program in Maine in 2006, and as of last year, they had 1,630 sites across the board here. You can see schools, daycares, after-school programs, cafeterias, healthcare practices, including practices, family practices that take care of adults, and even workplaces, which is not included on this graphic. So a lot of sites in their state working together to make a difference in the health of the population. I used to work at Community Health Alliance in Rito. In 2016, I used the 5210 messaging to create the Healthy Living Program to help families and children dealing with being overweight and having obesity. After the success that I was realizing with individual patients, we were fortunate to be awarded with the Wellness Frontier Award in 2019 from the Health Leadership Council. And we created a team approach, community partners, and following body mass index labs and healthy behaviors in our population, we were able to make an impact. And then part of the Washoe County Community Health Improvement Plan was to increase fruit and vegetable consumption and physical activity. And this model was rolled out as a community model with the county, working in conjunction with the Washoe County Health District. In 2018, we actually made a lot of progress, and it was very exciting. We actually got into 5 elementary schools in Washoe County School District right before the pandemic. And then unfortunately, things came to a halt after the pandemic started. But I'm very happy to hear over the last couple of weeks, I've been informed that the same schools and the health district or the school district in general has a renewed interest. And I think I get more enthusiasm than before to participate with 5210 program. So I'm looking forward to see how this rolls out. And I've found out that the Washoe County Health District, through a state grant, has some funding to help bolster this program. So I'm looking forward to continued growth in Washoe County. So with that, in summary today, I'm hoping that I've made some impact in regard to the necessity for developing statewide programming, because this is going to require really a population approach to address not only obesity, but also chronic disease prevention and more importantly, wellness promotion. There's a lot of community-based prevention models such as the Let's Go program to build upon. I think the experience that I've had here in Reno and helping and develop the 5210 Healthy Washoe program gives us some good footing to potentially and hopefully roll out into the state to really improve statewide wellness. I do want to mention, as I already alluded to earlier in regard to data, we do need a comprehensive statewide surveillance system with good data. You can see, depending on where the data comes from and how it's collected, may not be as precise as we would like. And obviously, in order to make a difference in a problem, we need to have a good baseline, and we need to be able to follow data accurately to know if programs and policy changes are having a true impact, so we can make changes appropriately. There's also a lot of good policy recommendations that I've already touched upon. I urge you to go to the state for childhoodobesity.org to look more of this detail. It is important for communities to set reasonable expectations. We can see from that first graphic that I showed you, it took us 40 to 50 years to get to where we are. So it's going to, change is not going to happen overnight. We're looking at cultural change, lifestyle change for a population. So we have to be smart with how we set our expectations so that we don't get disappointed, because this is going to take years of commitment to make a difference. And to do this, it's going to take funding, personnel, and a lot of effort. I've received an estimate of approximately $3 million is going to be necessary to fund a robust primary wellness prevention program. And this is from information that I've received from Lily Helzer and her colleagues at the Department of Public and Behavioral Health. But when we look at this is not even $1 per person in the state of Nevada. And when you look at the medical cost, just the direct medical cost, not the economic cost that she presented to you a short while ago, this is really a drop in the bucket compared to those. So that's all I have to say in regard to wellness promotion and childhood obesity. Again, I appreciate for your ear today. If you have any questions, I'm more than happy to take those. This is me. Feel free to reach out via email or my cell phone. For this topic, I'm always available. Thank you.
Thank you so much, Dr. Shane. We appreciate that presentation. Do we have any questions from any of the committee members? Let's go to Assemblywoman Titus.
Thank you, Dr. Shane, for that presentation. I graduated from medical school over 40 years ago now, and the one true fact that we are still following that I learned in med school back then was to way to avoid obesity is diet and exercise. We are still talking about this many years later on what to do about it, but it's the same mantra: diet and exercise prevents obesity at all ages, and or at least helps limit the obesity. So it's concerning to me that we're still here, that we still have these issues that we continue to talk about. And what I didn't hear in your presentation was some collaboration with some community partners and some of that. We're talking about government things, but I didn't hear mention maybe, boys and girls clubs. I didn't hear mention getting into some of the preschools, some of these programs. And is the American Academy of Pediatrics engaged in any of those and actually actively pursuing some of those partnerships?
Yeah, we here locally with my experience here with the Healthy Living program that I helped create, and also Healthy Wash Show, we we've had some involvement with the Boys and Girls Clubs, also with the daycare program associated with the Boys and Girls Club here in Reno. Head Start, the CSA Head Start program. So there's, unfortunately it takes dedicated personnel. A lot of this work that's been done so far has been with volunteer effort, including myself. And really to make a difference, to get into all these programs, like I showed you in the state of Maine, you need a dedicated workforce. You need dedicated personnel to creating, face-to-face relationships and training these programs to, walk the talk.
All right. Do you have any?
I hope that answers your question.
Yeah, thank you. Do you have any outcome data on the Maine experience that from the 2020 to 2021? Is there any outcome data on that engagement, and has it affected childhood obesity?
Well, they do have a very robust data collection system that I'd be more than happy to send you. It's a large document. They do every year. They send out questionnaires and they do other measurements, including BMI measurements. We're looking at BMI data collected by the state, similar to our mechanism. They as far as BMI, effect on BMI, that's been kind of plus or minus. Up until the pandemic, they had shown some stabilization in a number of age groups. They definitely have shown that since they've instituted this program, that they've positively impacted behaviors. So those 5210 behaviors have definitely improved throughout the state in the various settings that implementation has occurred. So in schools, daycares, and other settings. I think, as I alluded to, as far as setting expectations go, I think myself, including other experts in the field, our primary focus is lifestyle and behavioral change, because we know that in and itself can make a difference in chronic disease risk, regardless of weight change. I have to say that, a lot of communities and organizations that implement this kind of programming don't always see the rapid change or as much change in body mass index that they like to see. I think sometimes it's related to the fact to data collection on how the data is collected. But I think I could, if you would like, I could send you to the committee their annual report. I think it would be very educational for folks to take a look at that.
I certainly would appreciate that. I'm sure other members would. And I just want to thank you for your dedication and recognizing that being fit isn't necessarily a BMI. It's an overall mental health and a whole bunch of things into that. So again, thank you for your dedication. Thank you, Mr. Chair.
You're welcome. And I could also add that, that once the Healthy Community Study I showed, that included Maine. And the one part of the country that had the biggest difference in BMI improvement was in the Northeast. And they've had the most community-based programs implemented over the last 10 to 15 years compared to other parts of the country. So indirectly, that gives us a hint that this kind of programming is making a difference.
Thank you so much, Assemblywoman. Quick question for you, Dr. Shane. given your experience and your advocacy efforts throughout the state, have there been any conversations that you're familiar with reforming the school lunch programs that we have in schools? As the youngest legislator, I distinctly remember that in high school they would feed us pizza for breakfast, cinnamon rolls. Wasn't really healthy, wasn't really culturally diverse of what they were feeding us. And so, I mean, we had farms, small farms, maybe 3 plots in our elementary schools, but we didn't do a good job at educating all throughout K through 12 in terms of what healthy eating looks like, and especially during college. So what are the efforts that you see on the baseline of this subject, and are there reforms that are necessary to continue to improve these reforms?
Well, that's a great question, because unfortunately there's still a lot of pizza, hamburgers, and other foods that we know associate with healthy nutrition being served at schools. Believe it or not, since the 2010 federal lunch program overhaul, studies have shown that kids who participate in the school lunch programs actually do have better weight status than kids who do not participate. But still, that doesn't mean there's a lot of room for improvement. And one of the policy recommendations, for instance, from the state of childhood obesity, is to continue to work on ongoing reform and improvement in the nutrition that we're offering to the children in our schools. I know in Washoe County, I was just on a stakeholders group for the student wellness for Washoe County School District, and we've just kind of resurrected this group in April after over 2 years of hiatus. And the current director of school nutrition is very enthusiastic with the 5210 programming. And I had mentioned there were 5 elementary schools that are participating in implementing and piloting this program. And currently they're looking at modifying their school lunchrooms, utilizing the Smarter Lunchroom scorecard, which came out of Cornell University several years ago. So there is work here, at least locally. Hopefully this can become a statewide movement. But the short of it is, we're working on this, but it's a slow process. Great, thank you. Yeah, I would encourage any of the members that you are familiar with in the community to perhaps bring policy recommendations on this issue. I distinctly remember that while we had the free and reduced lunch, I went to a Title I school in Las Vegas. While we had the free and reduced lunch available to students, there were fundraisers from student groups that allowed kids in high school to buy burritos or whatever, Jamba Juice, whatever the alternative was, and those always had the longer lines than the school meal program. So I think there's definitely an overhaul that needs to be taking place. Chair Peters, I believe you have a question, so please begin.
Thank you so much, Vice Chair. I have 3 kids in the school system, and this year we experienced like the punishment through loss of your recess privileges, right? As a product of behavioral challenges in the classroom. This is one of the children. To me, I was like, this is kind of backwards. When my kid's acting out, the best thing to do is throw them outside, run some energy out, and then, re-engage with the behavioral issue after that. But there doesn't seem to be a standard of that in our school system, right? So how do we integrate and ensure our kiddos are getting these outdoor exercises, the school lunch that Senator Doñate was talking about, and nutrition issues, and ensuring we're integrating that with like overall behavioral health and overall understanding of like what is the best thing for and ourselves. And this kind of goes back to, I think, what Dr. Woodard was talking about earlier with understanding like health literacy promotion, right? Like that when you're having a hard day, maybe sitting in the corner while your friends go out to play is not the best way of dealing with it. If you're having a hard day, maybe going outside, practicing some behavioral changes is the best thing for you. So I'm curious if there's any policy discussion going around between your office and the agencies that you work with and the school districts on these issues, similar to what Senator Dunyate was asking about. That could be a follow-up, but my real question has to do with really this challenge we have on seeing obesity through the lens of like your physical, the physical scape, right? That has a lot to do with and you had a beautiful slide up that showed all the dynamic issues around what causes obesity and what causes health challenges related to obesity. So my question is, in the world of science around obesity, what are we doing to address these dynamic narratives? What are we doing to reduce this victim mentality that a person is obese because they have behavioral problems, right, that need to be addressed? What are we doing to scope out what are epigenetic issues that maybe we as a society need to change our behavior to help support communities who have a propensity for obesity because of the treatment, the historic treatment? What are we doing around that space? That's my real question for today.
Well, yeah, those are, obviously you've highlighted how complicated this issue is. I mean, first off, training healthcare providers about this disease and the factors that surround it, and also how to address patients, not intimidate or blame patients for their health problems, particularly if they have obesity. I think that's the first step. And I actually failed to mention that. It was a big omission, but I'm sorry, but I failed to mention that I'm currently working with the Division of Wellness Promotion and Chronic Disease Prevention to roll out, and I'm not sure if you're aware of this, a 5210 based program for the state, using some funds, some federal funds the state already has. And the first issue to tackle is providing training and education to providers on to promote 5210 and all these issues that you just brought up in regard to addressing children and adults with obesity. But overall, I think, and ultimately that the goal is to hopefully have a statewide program such as we've tried to develop here in Washoe County. They hit all those pieces of the puzzle, all the different sectors of a community, to look at wellness promotion and obesity prevention in the same way. And that's it's going to take some work, as I had alluded to with that one study. It can be done, but the communities that have done the best, like Maine, you have to get the whole community behind it. You have to get buy-in, and it takes some dedicated professionals to and a long view. You have to look at a long picture. You just can't look at a quarter or a year. You got to know that this is going to take several years to really turn the tide. So I don't know if I answered your question. I hope I did, somewhere in there.
I appreciate the comments that it is really an issue area where we, I think, societally and culturally have to address our own biases that are heavily steeped in body image, and looking at other factors that add into lifestyle and much farther than choice, right? And it's not just choice. And there are people I can think of across the spectrum, including, our teachers are integrated in this as they address our kiddos at school, and when they're seeing our children's lunches, either through the school lunch program or packed. We have professional trainers and gyms who are a part of this. We have a whole community based around how do we address our bodies and our physical well-being, but it's so much more dynamic than that. And I think one of the pieces I'm really looking forward to having a better social conversation around is the component of genetics, really, that not everybody's built the same and our bodies don't function all the same. And we don't understand a lot of that yet. It's not in the common intellect of our community. And so how do we better develop that? And where do we start? Is it through a health education program in our school district? Is it through the counties taking on public advisory efforts to ensure people are hearing this new language and talking about our health and well-being and physical being in a different way? Like, where do we put these funds to ensure that our community is elevating out of the space of really body negativity and into a space of well-being? I can even think of our business partners. Insurance has stepped up and started providing coverage for gym memberships and things like that. I just recently got hit with a new app to track my emotional well-being and encourage more physical integration into emotional well-being. So there are a lot of players who are in this space, but as a community as a whole, I really look forward to folks like you advising us on where's the best place to put these funds. How do we ensure that we're using the right language? How do we make sure that we're really diving into what the real problems are, and not just blanket stating that BMI is the standard for obesity, and then the expectation be that behavior change around that.
Yeah, and actually, I'm actually have become not only as a colleague, but I've become a friend with the woman who developed and directs the program in Maine. And over recent years, they've really tried to get away from saying that their program is an obesity prevention program. I mean, obviously, we would love to improve weight status in individuals, but really their number one goal is to improve lifestyle and behavior. And I know obesity medicine specialists such as myself, across the board, really focus on habits and lifestyle. And in order to, and not only as a healthcare professional promoting this kind of messaging, in a community program, this would be done through implementation with perhaps a coordinator that would go into an elementary school who was interested in creating a healthy environment for their children. And through that process, that implementation process would impart the importance of behavioral change, lifestyle change, and the weight status is a nice secondary benefit, but it's not, a primary focus. I hope that helps. Give some more perspective.
Great. Thank you, Dr. Shane. Chair Peters, did you have any other questions or?
No, thank you so much. Thank you for the responses.
Sounds good. Anyone from Las Vegas with any other further questions at this time? Don't seem there's any.
No questions here. Thank you.
Great. Thank you so much again, Dr. Shane, for presenting. At this time,
thank you.
We will take a short recess so that we can go ahead and break, and we'll turn back with a presentation from Dr. Packham on the healthcare workforce supply and demand in Nevada. So we'll do the break with the return at 12:45. Great, thank you. All right, welcome back to our meeting, the end of recess. Let's go ahead and proceed with our next presentation items. It looks like members are getting back from their lunch. So we will start with the presentation on our health workforce supply and demand in Nevada, the implications for chronic disease prevention and treatment. We have Dr. John Packham, who is the co-director of the Nevada Health Workforce Research Center and policy director at the Nevada Public Health Association. So please proceed when you are ready, sir.
I am ready. Can you hear me, Senator?
Yep.
All right. Thank you for the opportunity to speak today on health workforce issues and try to tie them to a lot of what you've already heard about chronic disease prevention and treatment. The information that I'm going to be sharing with you today, move my slide. Information I'm going to be sharing with you this afternoon, a lot of it can be found on our website and as well as reports that we post on the Office of Statewide Initiatives website. Today, I'm going to make a few comments on chronic disease and prevention and argue throughout that there's an important role for health workforce development as we think about both primary as well as secondary and tertiary prevention. I'll spend a little bit of time mentioning factors that are driving health workforce demand in the state, as well as trends in workforce supply with a focus on shortages. And then I'm going to conclude with some policy measures to address all of the foregoing. We think about prevention and workforce development in building on some of the previous presentations. I'd like to argue that there is a role, a unique set of workforce development issues for each of those three buckets of primary, secondary, and tertiary prevention. I'm going to devote most of my attention, however, to secondary and tertiary prevention, but building on what a great presentation before me by Dr. Shane, would just argue that that when we think about primary prevention, there's of course a role for core, what I'd call core traditional public health professions, education and training, which are sorely underfunded in the state of Nevada, long history of that. But I would also argue, and Dr. Shane is a great example of the importance of building public health competencies into a wider range of clinical and non-clinical occupations. Both UNR and UNLV offer dual degree programs for students in medicine and nursing that tie them to MPH degrees and other public health training. When we look at secondary and tertiary prevention, I think the big issues and challenges are what we do to expand both the primary care and specialty care workforce, but also the need to adopt or address team-based care in all sorts of ambulatory care settings. When we look specifically at chronic disease and associated workforce challenges, just highlight a couple of elements that you see in the literature addressed by researchers and policy analysts. And I would just start out that a lot of the training and delivery systems that characterize healthcare in Nevada and the US are still rooted in that standard 15-minute office model of episodic illness. Likewise, as you heard in the discussion on community health workers, we still have uneven reimbursement models when it comes to care coordination, patient navigation, and so forth. I'm hoping that one of the legacies of the COVID-19 pandemic will be reimbursement and policy that reflects what we've gained from expansion and reimbursement of telehealth. In Nevada, as I will argue, these are all compounded by persistent workforce shortages, particularly in primary care, particularly when we look at the pretty severe maldistribution of physicians and other providers by specialty and geography in our state. I'd highlight just one example of the importance of stretching the workforce, but also attending to what would be needed as we move to more coordinated team-based care, this highlighting cancer care. This is a great report. It's a little bit dated, And I think if this were updated or refreshed, you'd see additional roles for community health workers and those assisting with patient navigation when it comes to this type of chronic disease care and treatment. I would argue it's kind of the glass half empty, the glass half full approach, though, in thinking about those challenges or what we know works. And these involve both policy measures at the state and federal level, as well as actions undertaken by industry and employers of individuals engaged in chronic disease prevention and treatment. I think that this will always be at the top of my list, and that is that we need to continue to make progress and build on efforts to grow our own and keep those we grow through support for public medicine, nursing, and other allied health programs. We also need to address the associated training mismatch. And again, I think we're seeing that in all of our health profession school through interdisciplinary training, as well as training in outpatient and primary care settings. And again, a lot of those measures don't necessarily require us to produce more health professionals in some instances. They do call on us to think about how we stretch and make the work of those individuals more efficient. Finally, as I kind of put my public health hat on, a lot of these workforce challenges can be addressed by greater attention to some of the upstream prevention and population-focused strategies that were discussed in the foregoing presentations that have nothing to do with workforce, but everything to do with primary prevention. Whoops, went a little fast there. Just a quick note on the way workforce challenges in our state are compounded by forces that aggregate or aggravate rather, or worsen demand for healthcare and health services in our state. And I think as we slowly climb out of the pandemic, we will need to pay attention to those drivers. They include population growth and an aging population. They also have to do with rather substantial gains rather in insurance coverage by both public payers and private plans. Economic growth, additional population health needs, and health system issues are additional drivers ramping up demand as the pandemic hopefully winds down. But I would argue that those demographic factors are at the top of my list. I think we'll also, as a state, need to pay attention to what the demand for healthcare looks like post-pandemic. What we've seen already in Nevada and elsewhere in the country is hospital employment almost returning to pre-pandemic levels. Ambulatory care absolutely has reached pre-pandemic levels in terms of healthcare employment in clinics and offices and other outpatient settings. One of the wild cards, though, again, will be some of those temporary measures that we saw during the public health emergency relating to insurance coverage, telehealth provisions, and so forth. So there are some wild cards. Regardless of what Packham says, I would argue that industry is signaling through facility construction, inpatient and outpatient, both north and south, is anticipated steady increasing demand for services. When I turn attention to supply, I just want to note or recognize a couple of trends. That top of the list would be, again, persistent workforce shortages. I'll provide a couple of illustrations of how enduring those are and their impact on chronic disease prevention. I'd also argue that we have kind of a good news, bad news story in many professions, in both medicine and nursing, for example. We've seen a nice steady growth in the number of licensed professionals, but in some cases and in some regions of the state, we're treading water. And what I mean by that is that when you adjust that growth in licensees with population growth, particularly in southern Nevada, we're almost treading water. Unlike medicine and nursing that is still seeing a growth in per capita health professionals in our state. In behavioral health, we have not seen that. When you look at the number of licensed psychiatrists and clinical psychologists, we have not kept pace with population growth, and that's one that keeps a lot of people up at night. I've also alluded to a related trend as our state continues to age. That is, the average age continues to rise. We also have an aging health workforce. They're not separated from the populations they serve and are, again, an important supply characteristic. I'll also highlight the geographic maldistribution of health professionals, and all things being equal, we see those shortages being much more severe in rural areas of the state as compared to urban. I think we also need to pay attention to the diversity mismatch between providers and the population served. If you have time, there's a great op-ed that was in the Nevada Indy yesterday from Oscar Delgado. In addition to being a Reno City councilman, he oversees the Community Health Alliance and FQHC up here in North, and he was making a really great case for attending to improving the diversity of our health workforce so that we can address issues of trust. The previous presentations on immunization and variation by race and ethnicity are a reminder that you build trust in the health workforce when that workforce reflects the communities that they serve, and that includes people of color needing providers of color to oversimplify matters there. Now, when we look at workforce shortages, this is a map that sadly hasn't changed much in presentations I've made over the last couple of years. Upwards of 2/3 of our state's population reside in a federally designated primary care health professional shortage area. It's actually a very similar story with respect to dental health, and as you saw early in Dr. Woodard's presentation, even worse when it comes to mental health professional shortage areas. But I will argue that when we think about secondary and tertiary prevention of chronic disease, addressing these primary care workforce shortages would be at the top of my list as an important policy matter. Just kind of rounding out that discussion is this is a relatively recent data from the County Health Rankings and Roadmaps data release. And this just underscores the huge differences between urban and rural areas of the state. The urban figures are in dark blue, the rural areas of the state are in the light blue. And we have some counties, Lyon County and Pershing County, for example, upwards of 6,000 residents for every primary care doc. I would also note that most of those bars there are higher than the US average of 1,310 residents per primary care physician. So interesting geographic variation in shortages, in this case, primary care physicians per capita, but levels almost uniformly lower than national rates. Kind of closing out the discussion then of shortages and so forth, Dr. Woodard presented a little information earlier on what it would take if we had population to provider rates similar to the national average. Information we shared with attendees at a nursing summit last week. This is just a staggering number. Just to be average, our state would need 4,300 additional registered nurses today to be average. I want us to aspire to be more than average, but that's what it would take there. And you see other important categories, including primary care physicians and other members of that chronic disease management team. I'd like to then shift and kind of close and round out my discussion by talking about ways we address these shortages. And again, I take a positive view of this because most of the measures that I'm going to discuss in the remainder of my presentation are policy strategies that state and federal governments can take to address these shortages. As I mentioned earlier, there's no substitute for growing our own, and that simply means increasing the number and diversity of healthcare education graduates spanning from medicine and nursing to allied health, to oral health and behavioral health and so forth. that would be at the top of my list. There's also a number of policy measures that we can undertake to stretch the existing workforce. I'm going to keep mentioning team-based care in the context of chronic disease prevention, but I would also argue that measures like telehealth, as we've seen during the pandemic, a great way to, we're not increasing the workforce by a single provider with telehealth, but we are making more efficient, productive use of that workforce with a lot of telehealth adoptions. Finally, and apologies to Hamilton, I stole this line. There are just kind of a grab bag of beg, steal, borrow, and barter measures that we can undertake. Some good, some completely unsustainable, like the use of traveling and contract nurses, but should be a part of the conversation. When we look at grow your own strategies, I'm not going to go through this list. I'm happy to speak to any one of these, but kind of at the core of these are measures that we can take to increase both the number and diversity of graduates. And I'm going to provide a good example of that. I'd also like to argue that when you couple grow your own strategies with what we know works to keep those individuals in the state, that's I think needs to be at the core of what we do as a state to address some of those shortages that I alluded to earlier. One of the unqualified successes in this category has been the work that the state has undertaken to expand graduate medical education. That is the training of physicians as they enter residencies and in many cases fellowship programs and become ready to practice. This figure highlights that beginning with the first wave of GME grants, then Governor Sandoval legislation on, at that time it was $10 million over the biennium for GME grants. What we saw is a real nice steady growth in the number of both residents and fellows. The residents was much more impressive, but this is a great development because in addition to increasing the supply of GME graduates or those completing their GME training in Nevada, we do a pretty good job of keeping those. We keep anywhere between 50 to 60% of those completing their GME training in Nevada. So as that pie expands, so does the slice who ultimately remain in the state to practice. I would add, again, with your grow your own strategies, measures that we've undertaken to keep our own. Full disclosure, my office oversees the Nevada Health Service Corps program, but this small but mighty program that the legislature has supported is just a great model of a program that matches individuals that need loan repayment. I know very few physicians or nurses that don't need some form of loan repayment or assistance with that. But this matches those seeking that with those in return or exchange practicing in a medically underserved area. The individuals in this picture is a PA and a nurse practitioner that work in the clinic in Lovelock, Nevada, Pershing General Hospital, and a really good example of how we address, at least in rural areas, both primary care and behavioral health care capacity. Going from 0 to 1 nurse practitioner providing behavioral health services is huge in rural areas. I know the behavioral health issues in Clark County and urban areas of the state are staggering, but this is a great way to think about how we address those workforce shortages in rural areas of the state. In this slide, I've listed a long list of ways that we stretch the existing workforce, and I think the most appropriate one for our discussion of chronic disease prevention is expanding team-based models of care. That needs to be coupled with interprofessional and team-based education of those individuals. We're slowly moving in that direction. I think it also means thinking about ways that non-physician clinicians can practice at the top of their scope. We saw a number of states look at ways, for example, that physician assistants could practice at the top of their scope, maybe expand their scope. That's a trickier conversation. But again, in each one of these are ways to extend or stretch or make more efficient use of existing health workers. Great little example of what we accomplished as a state when we expanded the scope of practice for advanced practice nurses and expanded programs training physician assistants. I've double-checked these numbers, and what we've seen in less than a decade is a pretty spectacular growth in both the number of licensed individuals who are advanced practice nurses in our state. We're a net importer now of those individuals, but we've also seen really impressive growth in the per capita number of APRNs in our state. This is a trend you will not see in any other profession, and that is a near tripling of the per capita number of advanced practice nurses owing to that change in full practice authority coming out of the 2013 legislative session. I'll close out my list here by just talking about some measures that our state can take or revisit when it comes to benefiting from individuals interested in relocating in Nevada to practice. Some of these are completely unsustainable. Traveling nurses, for example, there were hospitals in Clark County paying $200 an hour for traveling nurses and $50 an hour for nursing assistants. The necessity of the pandemic forced us into that situation, completely unsustainable. But there are measures that I would mention that we should absolutely consider as a state. And one of those is the Nurse Licensure Compact. This sadly and unfortunately was a bill that didn't even get a committee hearing in the 2021 session. I would argue quite strongly that it's one that the legislature needs to revisit. The licensure compact is not going to be the be-all and end-all when it comes to addressing shortages, but it will be an important part, at least in the case of nursing, for our state if we're going to have a comprehensive approach to addressing shortages. I recently read in the Board of Medical Examiners' most recent annual report that our state in 2021 issued licenses to 1,158 physicians in the last calendar year. 454 of those individuals, or 39% of those new licensees, were a product of our state's participation in the interstate medical licensure compact. So again, it needs to be a part of the conversation of how we as a state address those issues. As I noted at the beginning of my presentation, a lot of this information can be found on publications and data resources on our Office of Statewide Initiatives website, and I would be more than happy to address any questions you have.
Thank you so much, Dr. Packham. Any questions from, let's go with Assemblywoman Titus, and then we'll go to Assemblywoman Gorlo in Vegas. So Assemblywoman Titus.
So thank you, Dr. Packham. Always good to hear from you, and you are the data person, and I agree with that. The nursing compact legislation, as you know, Assemblyman P.K. O'Neill and I co-sponsored that bill, and we're looking forward at bringing that back if nobody else does. Hopefully the state will get on board with that one because we think that's huge. I have some questions regarding other areas that you might see where we can expand access to care and have providers. The nursing compact that you mentioned that I feel we need to move forward on. You showed us the one on physicians that expanded, but there's other healthcare professionals. Are there other professional areas that you see something along that lines could be generated, not just with nurses and doctors?
Well, yeah, and I would just mention real quickly that of the 8 existing interstate licensure compacts, we, for example, only participate in 2. We, as I mentioned, participate in the interstate medical licensure compact as well as the psychology interjurisdictional compact, say that 5 times real fast, but we don't participate, as I've noted, in the nursing, physical therapy, EMS. There's even an advanced practice registered nurse compact, and then finally an occupational therapy. So there's other avenues there. And again, what I said for nursing applies to those. It's not the be all and end all, but we need an all hands on deck approach to addressing workforce shortages. And that's a good example of additional areas that need the attention of the legislature, because those will ultimately be in your hands.
So do you, and thank you for that, do you keep track on the time across those professions of from application to actually time of licensure so they can actually practice? For example, I was on a state board of medical examiners years ago, and it would take months, sometimes longer, to when somebody applies for a medical license to get that license. Does your department keep track on what those numbers look like across those different professions and how long it takes to get people their license?
I don't, but I would recommend that you speak to representatives of those boards who should have that information. I'm not trying to dodge it, but between anecdote and what you hear from various stakeholders, you hear all sorts of different, you hear those individual experiences of it taking 6 months in one profession and 2 weeks in another. But that, again, reducing that time lag is one more strategy that we need to pay attention to,
right,
at the risk of stating the obvious.
Right. I would just, as you mentioned, my dental hygienist took over 6 months, 6 to 9 months, I think, to get her license. And when she had trained and was educated in California and passed all the necessary tests, but it took that long to get her license. So I was just wondering if anybody's holding those professional licensure boards accountable on the timing in any one spot, or do we have to reach out to each individual board to find that out? And that might be something our staff can do, is find out really how long it takes from each of those boards. That would be helpful. Thank you.
I completely agree with you, and I wouldn't say we should do that for the purposes of shaming one board or another. But if one board takes 3 weeks and another board takes 3 months, that the 3-month board stands to learn something from what others are doing more quickly. At the end of the day, we want to safeguard the public's health through this process and the important roles boards play. But again, if we can attenuate or decrease that timeline, that's one more tool in our tool chest.
Right, and the other question I'm wondering, you may not know the answer to this, and we can find out from the boards when we ask them how long it takes, is there a temporary licensure status that can be applied for across these boards if everything else looks good and they're waiting for a final letter of recommendation or maybe their certificate of graduation or something along that line? Is there a temporary licensure that we can award, not under the emergency provisions, but just under the provisions they're trying to get here? So that would be good to know which of those offer temporary licensures. And thank you, sir.
Yeah, and I think I will just agree with you that would be a good approach. And I haven't seen the latest data on this, but a year or so ago, when we were up to our eyeballs in the pandemic, both the medical board and the nursing board presented data on those individuals who received a temporary licensure through that Governor's Directive 11 during the public health emergency. And one of the, I thought, fascinating, undiscussed parts of that experience was how minuscule the number of complaints or patient safety issues that were associated with those individuals. And they all didn't move to Nevada to practice, but quite a few of them did through telehealth, as we're learning. And I think that type of information on the experience of our state, with which my recollection, this was like a 2-page application for that temporary license, needs to be examined, because it may be the case that we can do that just so that an individual can begin practicing without, going through all of the hoops that's required in the complete application process.
Thank you so much. Assemblywoman Gorlo.
Thank you very much, Vice Chair. And I had two quick questions. The first, you had in your slide presentation a list of the number of deficits for the different professions, with nurses being over 4,000. And I apologize, I can't get it up on my screen to say which slide that was. But do you by chance have a breakdown of what those deficits are per county, especially in the rurals?
I do not have that. I don't have it for every county, rather. I do have a report that I will share with Patrick and get to everybody in the committee, where we look at probably 75 occupations in the state. I do have data for Clark, Washoe, and then kind of the balance of the state, as well as the state metric. But I think that would be of importance, given the fact that 90% of the state resides in those two counties. But I will make sure that you get that information.
Thank you. I'd definitely be interested in seeing how that might look. And then the other question, when you're talking about the Grow Our Own, I hear a lot of conversations about that, and it seems like we're talking about perhaps taking a student that's just graduated high school and getting them into that pipeline. But have there been conversations about taking current people in professions and growing them within that pipeline? So taking a CNA and bringing them to the RN level, or taking a social worker and making them an LSW. What kind of conversations have been had around that?
There are some great conversations, and I would even argue some great work in our state in that area. And one I would highlight, that young woman I showed in my picture of, she's a Nevada Health Service Corps individual. She started out in that hospital in Lovelock as a nursing assistant, then went to Reno to get her bachelor's degree in nursing, and then a master's degree at nursing in that pipeline. The whole time wanting to return to Lovelock to practice, and her getting that degree, homegrown student, getting your degree and training in Nevada, and then the use of the National Nevada Health Service Corps to kind of seal the deal so that she could go back, practice in her community, and pay down her student loans and debt. It's just a great example of addressing issues all along that pipeline that you mentioned. I would also add that there's a lot of interest right now in people who are in the process of shifting and changing careers. There was a lot of concern during the pandemic that physicians, nurses, and other health professionals were leaving the profession. I think those were exaggerated. They were certainly changing jobs, but not the profession. I think we saw more interest, though, in individuals entertaining careers in healthcare as well as public health. Enrollments and applications to most health profession schools, including public health, are up right now, and those are good developments that we need to support with dollars and expanded capacity statewide.
Thank you very much. I'd love to hear more on how we could support those kind of initiatives. So thank you.
Thank you so much, Assemblywoman. Do we have any other questions from any of the committee members at this time? Chair Peters.
Thank you so much, Vice Chair, and thank you for the presentation. John, it's been really interesting to follow some of the data work that you guys and your office has been doing. We've been talking a lot about the bottlenecks in the pipeline, right? And where those bottlenecks are occurring. And at that nursing conference the other day, we heard from a few folks that some of that bottleneck is occurring within our educational institutions. And we see this really across the board, even in our primary education system. When we're looking for people who specialize in a field that pays really well, it's hard to bring them into academia. It's hard to bring them in to become teachers. And so I'm wondering if you have thoughts on what we can do policy-wise around those bottlenecks, specifically within the education systems, or if you can point us in the direction where someone has fleshed out some of the issues in those areas, and what some of the solutions might be.
Yeah, I can give you just one example I've been giving a lot of thought to recently, and that is how do we address that bottleneck that all of our state nursing programs face, and that is a waiting list of qualified applicants. Every one of those INSHE nursing deans and directors will tell you they'd love to expand capacity, but they already struggle with nursing faculty needed to train those individuals. There was data presented at our summit last week that indicated a associate degree trained RN graduating in Nevada will make more than Orvis or UNLV pay their assistant and associate level faculties. We absolutely have to address that. Now, that may be a conversation that needs to take place more within the system of higher education than the legislature, but one would hope that there would be a broad agreement that you're never going to expand capacity if you don't address something as simple and straightforward as what we pay nursing faculty.
I think that that's an important point to this conversation, just how many players are out there in the pipeline. That we have the educational institutions, and we can't tell NG what to do, but we can help establish the social license in the state of Nevada for what it is that our expectations are. We can help establish what our growth metrics should look like and tie those into other metrics that are established by entities that we don't control. So I think that there are some options in there, but I'm really interested in kind of trying to flush those out and see how we can establish a way to decompress those pipeline compressions.
Yeah, and to the extent that they're able and can do it, I'd like to plan on putting together, my office can put together a white paper on the nursing shortage over the next month. And one of the things I'd like to get data on from the nursing deans and directors is the number of qualified applicants that they turn away every year. Because what happens is those individuals that are on that waiting list and that are turned away due to capacity constraints in our nursing programs, they either attend a private college here in college or university for nursing school with tuition that is substantially higher than our public programs, or worse, they leave the state and never come back. And so we compound our problem anytime that we're turning away qualified applicants. And I think we're turning away quite a few still due to those capacity constraints.
Chair Peter, did you have any other comments?
Just a minor comment and follow up that I think there's also some messaging that could occur. I know when I was in college, the nursing program was really competitive. If you didn't have a 4.2 weighted GPA with electives, there was no way you could get into those programs. And I think that those standards have shifted, that we're looking towards some other metrics, but I'm not sure that message is getting out in the potential pipeline for our high school graduates and people who are looking to attend university in the state. So I think that there's also some opportunities there for us to break down some barriers that we've artificially, I think, developed out of the social narrative of who can be a nurse or who can be a physician and what that looks like.
Well, and that's a good reason why in that pipeline work, whether we're talking with middle schoolers or high schools, the emphasis that we need to place on STEM education, so that an 8th or 9th grader who thinks they might go into medicine, for example, but by high school realizes they're interested in nursing. If you've got that STEM background, you have a leg up on others pursuing those degree programs in health.
Thank you.
Thank you, Chair Peters. Do we have any other questions from any of the committee members, either virtually or in Las Vegas? Don't see any. So let's go ahead and move on to our final presentation, which is policy considerations on chronic diseases and prevention. We have Chris Syverson, excuse me for the mispronunciation, the chair of the Nevada Advisory Council on the State Program for Wellness and the Prevention of Chronic Disease. So please begin when you're ready.
Good afternoon. My name is Chris Severson. Can you hear me and see my screen?
Yes, we can hear you.
Good. Thank you. As this is the first time that I will be presenting to this group, I wanted to just take a quick second and introduce myself. And my slides are not moving. There. I am the CEO of the Nevada Business Group on Health and Nevada Health Partners, which is a nonprofit Nevada corporation which represents employers primarily in Northern Nevada. I'm also the chair of the Nevada Advisory Council on the State Program for Wellness and Prevention of Chronic Disease, the board chair on the National Alliance of Healthcare Purchasing Coalition, board vice chair of Nevada Co-Imagine Health, and I have been around benefits and health-related human resources for over 40 years in Northern Nevada. As I mentioned, our organization is a nonprofit dedicated to supporting employers through education, healthcare and benefits, disease management trends and competencies, healthcare consumerism, and purchasing of essential and ancillary healthcare services. These is just a broad brush of who our employers are. You'll see that we do represent a number of public and private employers in Northern Nevada and a few in Southern Nevada. I wanted to take just a quick minute to say thank you to the state of Nevada is one of the very few states in the country to address the ongoing issues of the coverage of surprise billing and to tackle prior authorizations and step therapy in cancer treatment. So great job. That is very beneficial to not only our state, but to our employer organizations. There are a few issues that I wanted to address today, one being wellness and the other chronic disease. Historically, attention has focused primarily on treating the issues after the fact, and very little focus on wellness and the idea of total person health and well-being. Well-being and wellness, you hear a lot now on the concept of well-being, which I think encompasses not only wellness in the traditional terms of physical health, but wellness has several dimensions, including emotional well-being, coping, physical well-being. And I know that we've heard a lot today on mental health, and I have to say, I am fully in support of advancing mental health in the state of Nevada. And to speak to Dr. Packham's presentation, certainly the need for more providers in the state is nowhere as deep as it is in mental health as well. In talking about total person health, we are talking about individual, family, community, and population, as well as biological, behavioral, social, and environmental. And why is this important? This is important because chronic diseases such as diabetes, cardiovascular disease, obesity, joint disease can also occur with chronic pain, depression, and opioid misuse. All of these conditions are exacerbated by chronic stress. If COVID has taught us anything, it is that stress and mental health really has a large impact on our physical well-being, definitely with a long-term risks of COVID. Understanding the conditions in which a person lives, addressing behaviors at an early stage, such as Dr. Shane talked about in obesity, and managing stress not only can prevent multiple diseases, but can restore health and stop the progression of a disease across a person's lifespan. Just another quick, why is this important? When looking at the total person health perspective, when a person can deal with multiple, all five, let's say, of the total person health areas, you can definitely reduce the number of chronic diseases and the impact of chronic disease that a person faces. What are we asking? And again, since this is my first time addressing this committee, I was not quite sure what you were looking for, but just we'll talk broad brush in policy areas. We're looking for committed, sustained current funding within our own state. Oftentimes we are relying on subgrants or grants from the CDC, which do not allow a lot of flexibility in state programming. We're looking for support on programming on two different levels. One is residents of the states, and those would be looking at underserved, underinsured, and at-risk populations. We are looking for employees of the state and then public and private employees as well. The second area I wanted to talk about was chronic disease prevention and management, specifically obesity, tobacco use, and diabetes. And one thing that we have heard today, all of these are interrelated, right? All obesity affects diabetes, which affects mental health. And there's so many areas where we cross over and have common themes and common needs. Obesity in Nevada is growing. I'm not going to spend a lot of time on this. I think you heard from Dr. Shane a lot about obesity and Lily Hauser as well. Policy considerations in mental health, in obesity. I know that Dr. Shane did a great job in covering those things relating to obesity in childhood. But I also would look at coverage for obesity medications and treatment options, looking at this as a standalone disease, requiring health plans, providers, and vendors to collaborate and cover evidence-based lifestyle programs such as the CDC Diabetes Prevention Program and the Diabetes Self-Management Education Program as well. Again, committed sustained funding within our own state to support community health workers, which we've heard about earlier, internet and electronic programs, which is sort of an advancement, if you will, from telehealth. A lot of programs now are app-based programs. The covering of registered dietitians and obesity management specialists within the state. Again, programming for residents, employees, and public and private employers as well. In tobacco use, I know that this group is probably very versed in the impact of tobacco in our state. We'd like to look at increasing enforcement of retailers to comply with, require mandatory retail and merchant training and increasing fines to those, revoking licensure for those who continually have repeated noncompliance offenses, utilize current funding and allocate funding to local communities, close the loopholes and include minimum distance requirements, and support community-based education. And then I wanted to talk about diabetes. And this is a program that our organization has taken on for several reasons. First and foremost, we found that when we looked at chronic disease states within our employer population, we found that most often diabetes is not a primary diagnosis, but it is a comorbidity in many other diagnoses, whether it be heart disease, kidney disease, and other illnesses. We found that diabetes was often a comorbidity. Diabetes is the 7th leading cause of death in 2019. Those with diabetes are twice as likely to have a heart disease or stroke than those without. There are 3 types of diabetes, and we're going to talk today primarily about type 2, which would be diabetes which can be controlled through diet, medication, or a combination of programming. In 2018, over 34.1 million adults were estimated to have diabetes, which 26.8 million were diagnosed and 7.3 million were undiagnosed. And one of the things that we deal with in my industry is the costs associated with diabetes, and direct medical and lost productivity attributed to those diagnosed with diabetes was $327 billion in 2017, which extrapolate those in today's dollars is just really incredible. The prevalence of diabetes is higher in men compared to women, American Indian, Alaskan Native, Black, and Hispanics adults, as compared to white and Asian. Adults 25 years and older with less than high school education, and adults 25 years and older with a household income. So we're definitely talking about a prevalence in the Nevada underserved populations. Policy considerations in regards to diabetes management would be to develop in-state funding mechanisms for diabetes prevention program and diabetes self-management program. We are relying on CDC funds currently that may disappear in 2023 and cover DPP and DSMES for state employees under current benefit plans as well as Medicaid. DPP programming is currently covered under the Medicare program. What we've been able to do is we have 6 of our employers who were able to pilot the DPP and DSMES programs. We did achieve over a 5% weight loss for those, and we are encouraging our employers to cover DPP and DSMES as a paid benefit program. And we have employers who are planning on piloting this program as well. We'd like to offer to pilot this program through the state employees program, state PEV program, and work with them as well. Lastly, I would be remiss if I didn't take this opportunity to just talk about other overarching policy considerations in healthcare, and I would be more than happy to talk about any of these more at length at a later date. One is to expand step therapy and prior authorization language outside of the cancer care that we do currently within the state. Continue to monitor and potentially cap the cost of drugs to ensure drugs to employers, plans, and consumers. I do a lot of work nationally on high-cost claims and high-cost drug claims. The drugs that we traditionally think of are cancer drugs, but I will say that MS drugs, multiple sclerosis drugs, have really overtaken just about those cancer drugs in regards to cost and usage. And then those orphan drugs that cover very rare but just incredibly high cost drugs. Working with high cost claims, with the removal of the claims cap by the ACA, the burden to states, employers, and individuals has skyrocketed and is very, very detrimental to those employers who are self-insured, such as the state of Nevada and the employers primarily that I represent. Support the coverage of biomarker testing and the use of precision medicine. Again, oftentimes this is in the drug area. I joke that in prescription medicine, we have often used a shotgun approach, if you will, where we will try multiple drugs one after the other to find a drug that worked. With many biomarker testing protocols that have been established recently, you can find the drug that works the first time, which would create not only a much better patient experience, but a much better treatment alternative. I'd like to continue to monitor the use of copay accumulator programs and the impact on end user and overall use of rebate programs, and also the advancement of health equity. We did find through COVID and through many programs that health is not equal to race and gender, and we want to continue advancing those. And then advance the support and use of primary care and advanced primary care for all individuals. That really completes my presentation. Thank you again for this opportunity, and I would be available to take any questions.
Thank you so much, Ms. Everson. Let's go to questions from committee members. Anyone? Doesn't look like we have here in Carson City. Anyone from Las Vegas? Looks like Assemblywoman Gorlo. Is that you?
No, I was just congratulating Senator Harris for getting a little fly. Sorry.
All good. Any questions from committee members, either virtually or in Las Vegas? I don't think I see any, so thank you so much, Ms. Everson, for your presentation. Greatly appreciated.
Thank you.
Let's go ahead and move on to our next agenda item 9, presentation on the work of the committee to conduct an interim study concerning the costs of prescription drugs. For this presentation, we have our committee policy analyst, Patrick Ashton, who will go ahead and present on this subject area. So, Patrick, whenever you're ready.